Good morning. It's past 10 o'clock. I'm going to go ahead and open the work session on Patricia Tilley's money, otherwise referred to as public health. I'm going to pass the gavel to Representative Mooney for a while I go tie my tie and get my things. I'm late today. Sorry.
Excellent. Ms. Tilley. First of all, before we begin, anything for the good of the order among our Division 3 members? All right. I believe we'll probably have a handout book coming up, and we'll know what page to start on so we can follow along.
Chairwoman Mooney?
Yes.
Will be leaving at 11:30 to introduce a bill, so I just wanted to excuse my absence at that time.
Thank you very much, and good luck with that. Thank you.
Good morning, Nathan White, Chief Financial Officer with the Department of Health and Human Services, and I'm joined here today with...
Good morning, everyone. My name is Patricia Tilley. I'm the Director of Public Health. Thank you.
Now, before you, we have provided two documents. One is the PowerPoint presentation, similar to the others that you've seen, and then we have also provided the budget briefing book that includes the detailed account information for the accounts in excess of $1 million. If you turn to the governor's recommended budget, it's on page 939 is where the Division of Public Health Services begins. And with that, I will hand the presentation over to Tricia Tilley.
Thank you, Mr. White. Welcome, Ms. Tilley.
Thank you. Good morning, everyone. So thank you for the opportunity to walk through our public health budget. In order for any state health department to support and protect the communities we serve, we need sufficient resources to respond to both state and local priority. About a few challenges that we face. Then we're going to dive into the many accounting units that are in public health. I have about 40 something slides and a 90-page budget briefing book. It's a lot. For the most part, it will be just Nathan and I at the table today, but we have our Deputy Director, Ian Watt, who's sitting in the back, and our Public Health Finance Manager, Shelley Swanson. In case you stump us with a question that we can't answer, they can back us up, they can phone a friend. We will be able to get the information that you need. So my goal for the next few hours is to go through the budgets, give you a high-level overview, with the opportunity to pause, dig deep in any areas of interest that you might have. So we have a slide deck here. If we flip to slide 2, our mission and vision on this slide represents the ways in both large and small that how our work is designed to prevent the spread of disease and help people stay healthy. That's sort of all of it in a nutshell. And we do that in partnership with policymakers and communities, and our core functions are not new. As the archives that sit outside my office indicate, we've been doing a lot of it as a function of state government for well over 100 years. Counting things, keeping track of health data, inspecting milk, food, make sure it was healthy, using our laboratory to diagnose disease and contain outbreaks, and ensuring that there are safety nets for pregnant women and infants, and that we address environmental hazards that impact health. More recently, public health has been on the front page of the newspaper for the past 3 years throughout the pandemic. Many of you may have gotten sick of us along the way, but I hope that we have time to talk about the million other ways, other than COVID, that we use state and federal resources to put this mission and these values into practice. And in fact, today's my day of props. I have with me as sort of my backup, this book right here is from 1882. It is the first published public health report that sits outside my desk. I have about 100 of these that sit out there that are really fascinating. So it's like there's my little backup here to keep me grounded. So on slide 3, at the broadest level, you're going to see the 10 essential services that provide a framework for all that we do, from assessing and monitoring population health status to investigating, diagnosing, addressing health concerns and problems, to improving our work through ongoing research and quality improvement. On slide 4, we put a little bit of a finer point on it. This gives a couple of additional examples of what we do and how it fits into those 10 essential services and responsibilities. If we start with protection, this includes our incredibly capable emergency response functions all the way, and then sort of spreads all the way to things like food safety inspections, not only of restaurants, but things like dairy farms and milk distribution. We look to scientific evidence to inform our strategies. This is where in places like chronic disease prevention excels. We know how to do things like diabetes self-management, and we know that there are effective supports to help people stop smoking, not only to improve people's lives, but also to save the state money in places like Medicaid and long-term care supports. Prevention is really at the heart of almost everything that we do, whether that's to ensure that we have strong primary care and public health infrastructure, or ensuring that all kids and all families have access to childhood vaccines. You're going to hear a lot about data as we go through our budgets and our programs. The numbers are behind everything that we do. And I hope you've spent some time on the DHHS data portal. I've talked about it a lot at other times we've met, or that you've had an opportunity to read important reports that we've put out. For example, this year, we have a report around our investigation of excess rates of kidney cancer in Merrimack. Very important work that we do in partnership with our friends at the Department of Environmental Services, as well as through multiple areas within the Division of Public Health. And finally, again, it's all about improving health outcomes, whether it is preventing adverse childhood experiences or using quality improvement methods to make sure our preventative screening programs are timely and that they actually improve outcomes. So if you slide to slide 5, this is where, this is sort of the ultimate. This is when we talk about health outcomes and data, everything rolls up to morbidity and mortality. We had an opportunity to look at this slide when I came earlier for our pre-hearing. This one has the added 2022 data. It is preliminary. It's got a little asterisk because death data takes a little bit while to become complete, but it's pretty close, is my scientific way of saying this.
Can we take a pause there for a question? Representative Hull.
Thank you, Chairman. Would you like to take questions now or at the end per slide?
On the first slide, go right ahead.
Okay,
please.
so
Thank
on
you.
slide 4, right, you mentioned vaccines for children.
Yes.
And I noticed that on Facebook, there's still ads running for COVID vaccines for children.
Yes.
Is that something you guys are still pushing?
I don't know if pushing is the word that I would use to characterize it. We want to make sure that it is available to anyone who wants it.
Okay, sorry, advertising. There may be a little bit of political bias in the term pushing. There seems to be compelling evidence that in the case of children, right, under those under the age of 18, that the adverse effects are significant and the relative risk of COVID is very, very low based on the data that's on the dashboard. Would we be better spent using that money elsewhere?
So I think primarily if you've seen some of our sponsored links on Facebook, they're really mostly focused at individuals 50 and up. That is the target group that we are advertising to right now, because those are, as you noted, the folks that have the highest risk of morbidity. We have lost children. We have lost young adults in this state. There have been deaths that are COVID related among young children, nowhere near the scale of those that are older. We just want to make sure that COVID vaccines are available to those people that want them.
And so drilling down a little further, we do know that healthy lifestyles, right, proper nutrition are things that are the best defense against some of these particular diseases. Does it not make more sense to spend that same dollars promoting things like reducing obesity, eating healthy, cutting out sugar, getting exercise, sunlight, vitamin D, the list goes on?
Sure. I think as we go through this budget book, you'll see that we spend lots of resources and quite frankly could spend even more if those resources were made available to us in doing those preventative activities. So, things like our chronic disease programs are really focused not only on adult things like diabetes self-management, sort of, which is when the horse is out of the barn, I think is the phrase, but also on ensuring that kids have access to water bottle filler. Sorry, thank you.
So,
I'm pretty loud.
so I also just want to add some context. I think the marketing that you saw on Facebook, my understanding is that's probably paid for the federal money that came through the fiscal committee, and that the fiscal committee greenlit the program on the understanding that this was making it available and not recommending that healthy kids get the COVID injection.
That is correct. Thank you, Representative Edwards. That is correct. And quite frankly, the majority of, again, some of those sponsored posts, if you look at them, are really aimed at older adults. Thank you. So we can go to slide 5, which is, sort of at the core of what we do, which is the things you die of in New Hampshire and everywhere else. As I noted, we added preliminary 2022 data. When we last met, I talked about the fact that COVID has actually probably slipped down over the past few years. In 2020, it was the 4th leading cause of death in the state. In 2021, it was the 3rd leading cause of death in the state. And by 2022, it looks like it's going to slip down to about the 5th leading cause of death, which actually is lower than probably the rest of the country. Again, all the states haven't landed on those final numbers because death data takes a little bit longer. What I will
Representative Irf.
Thank you. Do you have a graph that shows comparison of all-cause mortality over the past few years?
this is the list of all New Hampshire residents' cause of death. 20.
Right, but what I'm looking for is something that shows for each year all the deaths, one number, and then that number over like the last 5 years.
Yes, we could put that together if you wanted.
That'd be great. Thank you.
Okay, thank you. All right.
And I have to ask about the COVID-19 number.
Sure.
There's been a lot of discussion about the difference between dying because of COVID and dying with COVID.
Correct.
It's my understanding that by and large, the reported data is people who have died with COVID, not because of COVID. Is that accurate?
I would not suggest that that is completely accurate. New Hampshire has taken a very conservative approach to identifying COVID deaths over time. We review every single death certificate and ensure that it makes sense, that the way in which COVID is listed. Other states, historically, if COVID was somewhere on the list or there was COVID, that get counted as a COVID death, we actually ensure that there was a COVID positive test as well before we count it as a COVID death. Again, we can spend some time a little bit later talking a little bit about the epidemiology behind it, but we've been using a more conservative method to go through, review every death certificate and ensure that COVID was the cause of death and a leading contributor. Thank you. Other than COVID on this list, you'll see things like accidents, which is our unintentional deaths, which include overdoses. I just want to highlight your attention there. Again, those numbers look a little bit low at this point. We've certainly all heard the media and have worked with the Office of the Chief Medical Examiner to understand that that number is going to go up over time as we finish toxicology reports for the end of calendar year 2022. This is very concerning to all of us, and it is an example of a place that public health works hand in hand with our Division of Behavioral Health and with partners across state agencies and in communities to really address this issue of opioid-related or unintentional deaths along the way. Everything else has remained fairly static over time. Heart disease, cancer, chronic lower respiratory disease, that's really emphysema, COPD, asthma, as well as stroke.
So Representative Hull has another question.
Thank you. Under accidents, right, including overdoses, my understanding is the overdoses were somewhere like 400 to 500 round numbers. Is it time to break that out as a separate category? Yes, it is an accidental death. I get that.
Yeah.
But it's a significant portion of that accidental death. And it, in some cases, has direct ties back to either surroundings, lifestyle, mental health, a bunch of other things that precipitate people, right? They don't necessarily want to go overdose. That's not right. That's not the plan.
Correct.
So since it's probably more than half of that number. Is it time to break that out as a separate category and track it that way?
So that's a great question. Thank you for it. And I think what we've done by de facto is pull it out. This definition of accidental death is our national definitions that we use for the National Center for Health Statistics so that we can compare apples to apples across all states. But we certainly understand the need for breaking that out to look specifically, especially in a state like New Hampshire, to address specifically overdose deaths related other than as compared to car crashes or ATV crashes.
Absolutely. And maybe you just put an asterisk there
Yeah.
and somehow tabulate that out. It's a meaningful number considering it's more than half of that number for each year.
Absolutely. And I did not provide you the exact number with it right now because, again, I know that of all the things on the list, the overdose is probably the least complete data that we have at this point. Thank you.
Are there other questions? Representative Wallner?
I'm sorry. I have a question about something that isn't listed. I wondered, do you have the statistics on suicide?
Yes. So thank you. I don't have that number with me this very moment, but it does come down a little bit lower. It's usually sort of at the, it's in the top 10, but somewhere down at the bottom of the top 10. I've given you the top 6. So the suicide number is below. Usually I'm even going to refrain from just giving you the number off the top of my head. I can probably find that number for you, or Ian can find that while I'm sitting here. But, and the thing about suicide certainly is concerning for adult populations. That's fairly stable. What we have found is the adolescent number sort of does this. It's a little bit wiggly. Luckily, it's a relatively small number over time, but it does go up and down, which is when we look at trends, we almost have to look at the trends over time to get a more clear indication of whether the trend is going up or down. We really have to combine years. Yeah. Great, thank you. So if you slide into slide 6, this is how we meet all our goals. This is how public health is organized. In the upcoming, and this is just our bureaus, our org chart is sort of unwieldy, which is why I didn't put it, do a cut and paste. You often see many of the other divisions doing a cut and paste to their org chart. Our org chart is pretty big. So for the purposes today, these are just our large bureaus. In the upcoming biennium, we have moved from 7 bureaus to 8 bureaus. And as we go through the budget briefing book, we can dig deeper into any of those areas within each bureau. We are splitting, the reason we're going up a bureau is we are splitting what is now currently known as the Bureau of Population Health and Community Services. And we're splitting it for a couple of reasons. Currently, it contains all of our maternal and child health programs, our WIC program, our chronic disease and cancer prevention programs, and smoking cessation. And there is such a large number of federal grants within that section, that bureau alone. In fact, Division of Public Health has the most accounting units in the Department of Health and Human Services. The Bureau of Population Health and Community Services had the most accounting units in the Division of Public Health. It's more than almost any other area of the department combined. So we're splitting that up for ease of administration and really to focus some of the talent that we have there and the leadership to really now focus on the sort of the young child family side. And what we've changed that into is now the Bureau of Family Wellness and Nutrition, and then our Family Health and Nutrition, and then the chronic disease, cancer, smoking side is going to be the Bureau of Prevention and Wellness. So I will.
So
Yes.
on the surface, one could think that there's some redundancy here because you have a bureau that deals with equity issues, and then in the office of the commissioner, we have 7 people who deal with equity issues. So could you take us a little deeper to help us understand that there's not redundancy?
Thank you. That's a great question, Representative. So we have this Bureau of Health Access, Equity, and Policy. Really, everything that we do is infused with the notion of equity. We want to make sure that we reduce health disparities across the board by any groups of people. And sometimes that's racial and ethnic, sometimes it's rural, non-rural, sometimes it's age. There's all sorts of ways you can cut that pie when you're looking at health disparities. In that particular bureau, is focused on rural health and primary care. So again, sort of a rural, non-rural area. We also have some equity in terms of some access to services. So our therapeutic cannabis program is in there. Our PDMP is in that program. And historically, it has also held a new funding source, which was our health disparities grant, which I know Representative Edwards that you're familiar with. We've talked about that over time. That was really designed to be a large funding source to address issues of equity. So that's very different compared to the Office of Health Equity as it's currently standing. They're doing a lot of class standards, you know, making sure communication and language access is available to the entire department. And also, I'm very excited with Reuben Hampton, who's joined that, to really provide that overall arching issue, you know, sort of thought leadership around what health equity looks in the department. Our bureau is much more hands-on and in the weeds. All right, thank you. We can scoot into slide 7 then. And so here's where you're going to see just a few of the accomplishments of our incredibly talented team. First of all, you know, again, I get it that the rest of the world is tired of COVID, but I do want to acknowledge the work of that, and that the work continues behind the scenes to support things like our long-term care facilities, and to support hospitals, trying to keep people out of the hospital. That is the metric. You know, hospitalization and death are the metrics that are our North Star around COVID right now. And we still have people with COVID, and you know, hospitals are still impacted. We were very fortunate that this year we did not have the spike in the same way that we did last year at this time. We're all happy. I think, you know, a number of people would suggest that is because of things like vaccine, but it is also because we've got easy testing capability and, quite frankly, therapeutics. Therapeutics have been a game changer at keeping people out of the hospital. You'll notice that also, as earlier noted, that we have some sponsored social media posts. One of those sponsored social media posts is to really highlight that we have a therapeutics program that anybody can use to get telehealth services. You test positive for COVID, especially if you're 50 and over. You can call them up, get an appointment that day on telehealth, and get therapeutics at your pharmacy within a couple of hours. It's quite frankly one of the best programs that I've had the privilege to oversee. I get random emails all the time from the public saying, thank you for making that available. My doctor wasn't available. It was Saturday or something, and I was able to get the care that I needed right away. So I just want to highlight that as an accomplishment of the past year. I think the other place where we've had significant accomplishments, and we spoke a little bit about the last time I was talking with you, is really around how we've modernized our data systems. We've worked hand in hand with Dave Wieters and our Bureau of Information Services, with our Department of Information Technology, DoIT, and others to modernize electronic case reporting, modernize electronic lab reporting. We've built and operationalized our immunization information system, and our public data portal continues to become more robust. Again, something that we're very proud of. A lot more work to do, but we've really moved in light years through the as a result of the pandemic in some of our ways to report timely data and make it transparent to the public. And finally, I'm extremely proud of the work that we have done to support kids and families, and really focusing on prevention. You may recall last time at this year, not only were we had a spike of COVID, we also had no infant formula in the state of New Hampshire. And we had kids, you know, parents, you know, across the board and across the economic spectrum who literally could not feed their children. Extraordinarily hard, not only with our WIC participants, again, the Women, Infant, Children Feeding Program, to make sure that all of those families who were really the most vulnerable had access to formula, no matter where they were. But we were also fielding phone calls from regular old citizens across the state saying, how can I access? What's a good substitution? Help me through this process. It was incredibly stressful for new families last year, and I am thankful that we are done with that. The Abbott factory is back up and running, and we are returning now to a more regular scope of business. But again, as a highlight of last year's accomplishment, that's one that has been sort of quiet because it was also during, you know, COVID. Again, the media was focused on COVID. Many of us were focused on the fact that babies didn't have food to eat. So we can look at the challenges now. So those were some of the things that were great. I think slide 8 shows some of the challenges we continue to face. As we look forward to the next biennium, we know that we're going to need to continue to address the long-term impacts of the pandemic. Primarily, we have seen that the use of preventative services plummeted. And I think we know that, we've heard that in the media, but we've seen that play out in terms of things like a reduction in mammograms, a reduction of cervical cancer screening, a reduction in lead screening for kids. All of that has happened over the past 2 years. And so we will see the impacts of that. Yes.
So I love visual information. I'm just trying to figure out how to interpret slide 8.
Yep.
It looks like if I were to read it as the way I want to, is that the base of all of these other things above it is that we have adverse trending of health conditions. Are the colors and sequence and size of the blocks meant to communicate?
About it is that it is also scale of the problem. I don't think that it isn't designed to show causation or even necessarily correlation,
Okay,
but
so-
just really scope.
Yeah, so this is just
Scope.
relative impact.
Yes.
Thank
Thank you
you.
for that question. So again, we're going to see those adverse trending. We've also seen that in terms of behavioral health. That is also in all of our media feeds right now. We know the impact to adolescents. We know the impact as well to adults, and we're feeling that now. So that's going to impact all of our programs. We continue, if I go to the top of that, I look at things like environmental threats. That did not go away during the pandemic. We continue to try and manage our way and better understand the responses to things like increased excess cases of cancer in southern New Hampshire. So those are continuing to focus our time. Yes, sir.
Okay, so now that I understand it, you're saying that your workforce issues are enormously impactful.
I am. And I was
But
about to get there.
nevertheless, the adverse trending and long-term impacts of the pandemic are even yet more significant.
So they are related to some degree. As we have more work to do, we also are facing this workforce challenge that everybody is facing.
So I'm just trying to understand, because I understand the workforce issue, that's enormous.
It is
But-
enormous.
But like if you could reach in and pull out of the guts of the bigger bar, what do you see as the long-term impacts that are even more consequential?
In terms of health outcomes?
Of public health challenges. How is it that our health conditions are trending so negatively, or we have specific long-term impacts of the pandemic such that that's an even bigger problem than the workforce?
So I think the two go hand in hand. So the adverse trending, that's going to be something that we also don't know enough about right now. That's the whole point. Like the trends are going to go that are going in a different direction. We're going to have to figure out along the way what's going to change our priority and change the focus of what we do. And some of that is yet to we're going to have to figure that out when that comes, when we see those impacts. There's also things like long COVID. We don't know what long COVID is going to mean for people. We don't know if there will be additional resources. And then the other piece is just demographic. As we've seen, our population is older, as we all know. And as that baby boomer population gets older, we don't know how we are going to have, how to respond to what will be the problems of the future. When I look into my crystal ball, I certainly understand that with a lack of preventative services, cancer screening is probably the best. If you don't catch those cancers early, it leads to worse outcomes. I mean, that's a pretty simple, direct line. The workforce is side by side with that. And we have the same challenges that everybody else has. We are not special in that way. The only thing that makes us, just have a different focus on it is the types of people we need to do the work. In public health, we have almost 50% of our staff have advanced, or not just bachelor's degree, but have advanced degrees. We have almost 20% of our staff have PhDs. And these are folks that can go out into the world and make a lot more money than working for public health right now. They do it because the work is important. That's the thing we give to people, is an incredible sense of mission, an incredible sense of accomplishment and importance of their work. But at the end of the day, people have to pay their mortgage, and they're going to have to make those choices. And not only only is it an impact for the workforce of the Division of Public Health Services, we have equally seen that as workforce issues in the community. So when we have, we have been inundated with some COVID money to do some interesting things out in the community, we could come up with great ideas. We may have even had great ideas before the pandemic. We say, okay, community partner, here's the time to do this great job, this great work that you've always wanted to do. And they say, I'd love to do that, but I don't have any staff. And so that's the downstream effect of some of this, is that our healthcare providers don't have staff, our community service providers don't have staff. And so even if we have great ideas and the cash today to do it, that's been a constraining factor as we move forward. So I think that, again, for this slide, those are our big issues. We've got some health problems in the future that we don't really know about. We've got some workforce, and we're going to continue to have to figure out how do we plan.
Representative Stringham.
Thanks. Since you brought up long-term COVID and as part of the in the category of adverse trending of health conditions, how many people do we have with long-term COVID, and what's the mix of how severe they are, and what are the resources that are trying to address that, to understand that issue or address that issue?
The short answer is we don't know. We don't have a way in which to count that and get that data in a way that's meaningful right now. There's no standard way to code that. It would take us a while to get that data, even if we did. We typically, when we look at health outcomes, we usually have some standard data sources, whether that's something like our behavioral risk factor survey, which is a random survey that people say, yep, I've got heart disease and I've got asthma, and that's how we trend those things. We also use hospital data, again, to try and trend some of those health conditions. But typically there are ICD-9, ICD-10 codes that we can count on to do that. All of this is new for us. So we don't know if someone's having long-term neurological symptoms. Is that because of long COVID or is it not? I anticipate this is a place over the next 2 years where we're going to refine as a country, how do we count that data so that we can understand how to approach it, and then work with our clinical partners to understand what are the interventions that need to be put in place. Again, it's sort of this fuzzy thing that we know is out there, but I can't give you a hard number on it.
Representative.
So when you say, it's this fuzzy thing that's kind of out there, how do you know it's out there?
Certainly from our anecdotal information from our clinical partners in the state. There are also some smaller studies, the CDC and others, and have been working hard at trying to get some of that data in very prescribed ways, working with specific hospital systems across the country to really dig down and do the sort of data abstracting that you would need to do, going into the depths of those EMRs to pull that information out. We're not ready as a country yet to have to go prime time with a methodology to be able to get all of that data, to have a broad picture that is representative of everyone, but we've certainly seen through certain studies of certain health systems that it's there.
Can you provide those studies, please?
Excuse me?
Can you provide those studies,
Yes,
please?
we will do that. Thank you.
Representative Hull.
Thank you. Follow up on Representative Earth's question. Is it possible to work with one of the major hospitals or their groups to try and get a statistical sampling for long COVID? And I say that because I hear a lot about it through personal networks, but there's nothing I can point to in New Hampshire that says this is 1 in 5, 1 in 10, whatever the number is. I don't have a reference for how severe the total is. I am concerned that we haven't done much to address, right? There are, whether it's cognitive, whether it's respiratory, there's a number of side effects beyond just kind of aches and feeling groggy.
Yeah, thank you. So that's a great idea. I don't, this is a place, it's the budget meeting, it's fiscal meeting. I don't have a particular pot of money to do that work. I'll just be honest. That doesn't mean that we can't work and engage with our partners to help understand that. I think we're going to look to some of these studies. I know that there's something called an MMWR, which is the CDC's weekly reports that are like health reports. That's where we've seen some of those other long-term COVID studies. It's called the Mortality and Morbidity Weekly Report. MMWR. And so that's certainly a conversation that we can continue to have with folks like Dr. Chan and others who are working with our clinical providers to get a finer point on how do we count in New Hampshire. But and I'm sure you can appreciate the methodology of counting. We want to do that correctly.
Right. Okay.
Thank you. All right. So it's slide 9. This is just an added fun slide. I asked my staff the other day. So what you saw previously in slide 8, that's sort of our leadership and our staff sort of saying, these are the things that we know are going to be challenges moving forward. I asked my staff the other day at a staff meeting, I said, so what are the 3 things getting in your way of getting your job done? And so, you know, it's workforce, it's money, it's, you know, training, all of those things. One of the experiences that we've had through COVID is that while we have been blessed with large pots of money in some areas, that money is not flexible and it cannot be spread widely. You know, we get money for immunization, we get money to do a certain thing here. We have pockets of the division that have gotten no extra money and in fact have gotten cut over time. So while, you know, our overall budget has increased and we're thankful for that, it is unequal across all areas. And I think that this reflects that as well, our staff's feeling. You know, I think the other pieces that they feel as well, like everyone, they are coming out of feeling burnt out. You know, many of my staff, as I've often, you know, reminded folks, we're working for years at, you know, 24/7 pace. We had two shifts of laboratory working. We were just working nonstop. And I think sort of like the long-term effects of the pandemic, it's only now that folks are starting to take a breath and to feel they've been working on adrenaline for so long, and that has impact over years. And so we're feeling that. We've seen folks retire, I think mostly because they were age appropriate to retire, and that was our workforce. And we've seen some moving around. The thing that we have that's supportive, however, is this incredible purpose to the work. And that is what has kept people engaged.
I think there's a theme in here that you have more accounts than most departments. You get these targeted stovepipe programs that come at you from the federal government. It's causing issues in your workforce that there's not the flexibility. So isn't there a way to go back to the feds and try to get some waivers and get some relief so that all this money that they're putting in has some flexibility?
Thank you. Yes, we don't have waiver authority in the way that CMS does. CDC, you have to sort of the logic model that goes all the way back. Congress starts with their appropriations. So, you know, they say CDC, you're going to spend this much money on cancer and you're going to spend this much money on this. And then CDC operationalizes what they get from the federal government. And they have heard from all state health officials, including myself, like, please stop with the massively stovepiped funding or to allow us some flexibility. The good news is we have a couple of funding sources from them that have allowed us to do that. That's been a little bit more flexible to focus on workforce, to work on public health infrastructure in general. So we know that they have heard us that way. It hasn't fixed the problem, but they have certainly heard not only New Hampshire, but most states at this point. Thank you. So on slide 10, you'll see what I think is sort of the big takeaways from today that are not programmatic, but this is our budget. So we've got 124 million total budget. Again, that's not the COVID money. We talked about the COVID money before. This is our regular old budget, about 124 million. Only about 15% of it is general funds. There's not a lot of wiggle room there when you're talking about what can be moved around in a flexible way.
Representative Hull.
Thank you. So that 124, where does that show up in the budget book?
I believe that number is most likely from the agency phase. So if you turn to page 1014,
Thank you.
the governor's recommended 24, it's 130 million. Then state fiscal year 25, it's 130 million as well. What you're going to see there is primarily the increase from the public health infrastructure grant that Tricia was just referring to. It's about $5 million, and that was added during the governor's phase. So that's the one discrepancy there.
Thank you. Thank you, Nathan. It's good
So-
that we have someone who does the math.
We have more. Representative Wallner?
Thank you. I just was wondering about the 15% of general funds. Are most of those used for matching?
Many of them are used for matching, and then a handful, some of them are also used for things like food protection, stuff where we don't have federal funds to support that. Food protection is a mix of fees, and then the rest is general funds, because in statute, we're only allowed to keep $300,000 of our fees, like our licensure fees, and then everything else for the program has to be funded through general fund. We have a breadth of our.
We got more. Representative Irf?
Thank you. Since the word matching came up, I know this is not specific to you, but it's a question I've had, and I'm hoping maybe you can answer it. With regard to the 3.1% across the board rate increase, is that generally matched, like 50-50 in those compartments where it's 50-50 and whatever the match may be in other places?
Sure. So the 3.1% that we were talking about yesterday, that's Medicaid, and you won't really see that show up in the public health budget here today.
I understand that, but do you understand my question?
That
Is that federally matched when we do that increase?
Yes. So what you see like in the surplus document with the HB2 provision for the $17 million of general funds, there will be a match of federal dollars. Now it primarily, like if we're thinking standard Medicaid, that's 50-50. If it's CHIP, it's 65-35. So there are some nuances there, but yes, primarily 50-50.
Okay, thank you.
Representative Hull?
Thank you, Chairman. So on page 1014, thank you, Nathan. So is this a mandated 15%, 85% sharing by federal government, or what drives that 15%?
So there's a variety of factors, but we cost allocate many of our positions, and if a position is cost allocated, we need to be able to attribute a specific cost of the federal portion to the activity that individual is doing. And oftentimes, an individual could be working on a variety of different federal grants, but then there's a portion of their work that would not qualify for that cost allocation.
So this is not necessarily a statutory match. This is just where it is, right?
So public health receives hundreds of federal grants, and with every federal grant, there are specific requirements. So there may be maintenance of effort requirements within each one of those grants, so that we would have to put forward a certain amount of general funds towards that particular grant. Many are 100%, but some are not. It just depends upon the grant.
Okay, thank you.
Yes. Yeah, I would just underscore that it really is grant by grant, federal source by federal source, account by account of where you'll see, to Representative Wallner also spoke of this, there are going to be places where you see, I don't know if a lot of general funds, but more general funds, lots of places you'll see zero.
And that's part of the reason that we have so many accounts here, so that we can account for each one of those funding sources separately to try to make it clear, transparent, and much easier to manage.
Yes. Yes, there is method to that madness of all of the accounts, especially with the federal grants that come and go. We have some grants you'll hear. We're going to talk about the Maternal and Child Health Block Grant. We have had maternal and child health grants since President Roosevelt. That's a long time. That's a pretty stable set of money. And then we have other grants that change every 3 years. And so managing that is just part of the administrative work of public health.
I want to do a time check. We've got like 45 minutes in, and we've gone through just under
10.
a fourth of your slides. So I know you're stopping for questions. That's on us. But do you imagine the pace to naturally be faster than this in the next slides?
I would assume that the pace is going to pick up, but it will be dependent on the questions that you have.
Right. Okay.
I'll just refer them to the page number as you go through.
Great. So, and finally, just the last thing I want to point out on that slide 10 is really that the budget does two big things. It maintains our core infrastructure things that we just have to do. It is in statute. I think I shared the last time we met a little booklet of all of our statutory responsibilities. So we do that. You know, we're always going to have to inspect milk. We're always going to have to check for rabies. And then it also includes a lot of these federal priorities that sort of come and go at scopes that expand and contract. So that's the part of the budget that, again, is sort of the magic of public health. And then the other thing, if you're trying to match up staffing, we use a mix of temporary and permanent FTE. So many, especially over the past, I would say the past 4 years or so, or the past 2 bienniums, we have moved more to using 8T and 9T positions, which are state temporary positions. These aren't, you know, contracted. These are state positions, but they are associated with a particular grant, but it's not considered a permanent FTE. So sometimes you'll hear me say, you know, over the course, you've heard me say, I've got almost 400 staff, but it only looks like 250. It's because of the temporary staff and the way that we count staff in the state budget. Is that fair? All right, so let's move into 11. This is where the pace begins to pick up. This is our first set of budgets. It's the Office of the Director. That's me and just a handful of other people, but it's also where we administer the rent and the administrative work of the division. It's cost allocated from grants and generally funded staff.
And it's on page 939 of the governor's recommended budget.
Thank you. Is this, in which of your bubbles do you have the communications role, the one that helps draft any public health notices? Is that in your group or?
So currently, and I'll get to that. Currently, we do that with a lot of our public health emergency dollars. That is what funds our PIO, our press information officer that works under Jake Leon. But famously, we have this new public health infrastructure grant that creates a new communications person that's going to sit in the Office of the Director. And that's going to be a higher level strategic position to help us with communications. So, you know, again, I've got a staff of hundreds of PhDs and super smart people. Sometimes they like to talk to each other or at a certain level. And we've recognized that we need to do a better job of communicating with the public and communicating with our policymakers. Great. So we can jump into our first bureau, which is on slide 12. This is informatics and health statistics. It has a number of smaller grants, some of our surveys, things like the behavioral risk factor survey. We have moved our cancer registry back into this particular group. It had been in our cancer program. We think it fits better in with a lot of the other data.
So because there's not a lot of money for technology in here relative to the amount of informatics work that could be done in your area, I assume that most of the money to support the informatics function is over in Mr. Weider's budget somewhere?
Yes, that's correct.
Okay, so there are 10 positions in here. Of these 10, could you give us a sense of what their skill sets are then? Are they informaticists? Are they data entry people? Are they, you know, who are these 10 people?
Sure. So it's a mix. There's just a handful of them. We have informaticists in there, so folks that are really looking at the software and the hardware and making the data flow from one place to another. We also have a set of health statisticians that are making sure that our analyses are correct. We also have a number of these folks work on our DHHS data portal. So again, matching those two things, making sure the analysis is correct, making sure the informatics is correct so that it looks pretty in Tableau when you open up your website.
So one of the themes I've been asking about this cycle is the extent to which we have a mature data warehouse strategy and that we have the right tools that are used commonly to do the sort of the front end queries into the system. Do you know your technology well enough in this area to know if you're leveraging a common platform and system or if you're doing your own thing here?
No, we are certainly using the EBI, the Enterprise Business,
intelligence.
intelligence. I always forget the I, but yes, the EBI is at the core of much of what we do. We also have a system of legacy programs, however, that are programmatic and may have to do with all of those stovepipes of
Stovepipes.
funding. So a lead program and, cancer registry is a great example. That doesn't particularly use the EBI because it is sort of stood up, in a separate system. So, but the degree to which we can leverage that back end is where we've been going. Chawe Chala is our chief of health statistics and informatics. She probably spends half of every day with Dave Wieters in some capacity to ensure that as a department, we're working together.
Yeah, I know her through the vital records function. So
Super smart lady.
Representative Hull.
Thank you, Chairman. Sorry, I'm just catching up. I'm on page 940 still. Looking at lines 28 and then indirect costs from the last biennium going forward. Roughly there was $8 million spent in the department, of which $2 million was indirect costs. That $2 million goes away, leaving us about $6 million. Yet this year's operating cost is almost $7 million, and it predominantly shows up in transfers to plant and property, almost $1 million more.
Sure. So I'll answer the easy one first. So the indirect cost line, that was centralized to account 9,500 within the Office of the Commissioner. The transfers to plant and property, so the Department of Administrative Services charges us rent for the property at Hazen Drive, and they determine a square footage rate, and they provide us that figure, and then we pay them, and we don't really have too much negotiating room there.
Okay, so that's roughly a 25% increase. Is that going to be across all, right?
So the facilities that will be coming here, I believe maybe next Friday to present, we're going to be talking about the other half that DAS charges us as well, that shows up in the facilities budget. But this is limited to Hazen Drive. So
Is it just Hazen Drive? Does it also include our space in Brown and the warehouse? Just Hazen Drive. We heard it from the back.
So do you, when you come next time, maybe you're not prepared today, right? Because drilling down at this level, can you get dollars per square foot? That just, right? What is the facility? What is the total square footage at Hazen Drive? And what are we paying per square foot for that? A 25% increase seems significant.
I would agree, and I can absolutely do that.
I think
Okay.
there's a phrase that says the rent is too darn high.
Okay, Representative Stringham for a question.
Just follow up on that. Did I also hear you say that that the administrative 5110 account is then allocated to specific grants? So if your the rent you're paying is higher, you have more costs that can be allocated to specific grants, which may be reimbursed under those federal grants. Is that accurate?
I would have to follow up on that question. Is there an easy answer? Yes, we would be able to.
Yes, you'd be able to follow up.
Yes, we would be able to better leverage federal dollars to
Okay.
address that. So.
Thank you.
The only thing I would add is our federal dollars are pretty static. So again, we use those funds. What it means, as those allocated costs increase, even things like salaries increase or rent increases, it just means that we have fewer dollars to actually put out into community to do the work. So, that, and what we'll see as you go through these, we have many federal grants that are, less than $200,000 a year. And then we have some that are bigger that are several million, but especially on those tiny grants, on the, grants that are less than 200,000, all of the allocated costs really start squeezing into it and don't allow us to do necessarily the work that is intended to be done.
Thank you, Representative. All set.
Thank you.
Representative Norgren for a question.
Thank you very much. Sorry to be late. Crash on 89. Section line 40, indirect costs. That's zeroed out for 24 and 25. Do you?
Yes. So the indirect costs were centralized within account 9,500 within the Office of the Commissioner. So we moved those expenses to one central account from multiple
They're all
areas.
in one place.
Yes.
That sounds logical.
Yep.
Thank you very much.
Right.
Nathan, where is that? Which page do you know that went to?
It's on page 1069 of the governor's recommended budget.
Excellent. Please continue, Ms. Tilly.
Thank you so much. So on slide 13, this is just another one of these graphics we shared with you the last time I was with you to talk about sort of data modernization and public health infrastructure. And this just underscores that we've been able to use some of our COVID funding. Again, COVID funding doesn't show up in here, but we've been able to use COVID funding and other funds to really start thinking about public health infrastructure. In here, you'll also see at the end in the governor's phase, we added this grant that's called the Public Health Infrastructure Grant. It is new. It has not come to fiscal yet. So we don't have the full details. It's been awarded to us. We're still negotiating the budget line items with CDC, but fiscal will see that and we'll be able to provide some more detail. But I can tell you at a very high end that public health infrastructure and data modernization grant is going to help us with things like cancer epidemiology. That's an area where we just haven't, our cancer program keeps sort of getting smaller and smaller, and our needs for understanding cancer incidence is growing. So we're being able to use the infrastructure grant to get the kind of epidemiology support that we need to be able to do future work. So the other piece too on slide 14 is just a screenshot, not from our COVID website. It looks like our COVID website, but it's not. This is actually our opioid dashboard that we have on our DHHS data system. And this is a place where we've leveraged funds from something called Opioid Data to Action Grant that sits in another bureau, but a chunk of the money comes and sits over, is utilized by informatics in order to create this Tableau data dashboard that's available online, as well as to help support things like our prescription drug monitoring program to have the data support that they need to be able to present the data to look at opioid prescription data over time. So it's just an example of the way we sort of take all the those stovepipes and try to blend them to the best of our ability. We don't rigidly stay within each lane, but we're not always able to be as flexible as we want to. But when we can, we try and braid them across areas. So on slide 15, we jump into the Health Access, Equity, and Policy Bureau. Again, relatively small bureau, relatively small numbers of grants. As I noted, this is where some of our, sometimes we affectionately call this the island of misfit toys. We have things like our prescription drug monitoring program, our cannabis program, as well as our rural health and primary care programs. And I'm happy to answer any questions about those. All right.
Representative Mooney?
Thank you. If you don't mind, I'd like to go to the cancer registry just a bit. I see that was on your previous slides. There is a bill forthcoming related to Merrimack, House Bill 614. That's right. And the question is that money in that bill contained in the budget we're looking at?
No, it is not, but it would be support. It would enable us to do, so 614 is a bill that would like us to take a look at a feasibility study to understand whether or not we need to open up an entire case, do some real in-depth case understanding of what's going on in the excess cases of kidney cancer in Merrimack. So the funding that's here is simply to maintain the cancer registry and to have a little bit of, we contract with Dartmouth, the support that it takes just to do the cancer registry. And so the 614 would be additive to that, but it would use the data of the cancer registry.
Okay, thank you. Next question is, with regards to that cancer registry, how many communities benefit from that particular section of the budget, would you say?
Every community in the state of New Hampshire, people with cancer, it represents the data for all people with cancer in the state.
Thank you.
Representative Holt?
Sorry, Chairman. We're probably destroying your timeline. On page 15, therapeutic cannabis program. Right. As we start collecting this data, what happens to the list of individuals that participate in that program?
So thank you. So that is confidential data. So we keep it, it is separate. Unlike we were talking about the EBI before, where we try and use data across systems, the therapeutic cannabis program is completely separate, in part because it is still federally illegal. And so that is kept in its own separate box.
Okay,
Good.
so that data isn't shared with any other departments, internal, even within the state?
No.
Thank you.
I would also assume that they have privacy procedures in place that before things go into the data warehouse, it's been scrubbed of
Correct.
PHI.
Correct.
So they're looking at anonymized data.
Right.
Right.
But the background data, there is still PHI in the background, usually, in order to make some of those connections. But for cannabis is in its own system, separate. We have its own data system. It's, again, one of the challenges we have in public health because we sometimes have these one-off systems, in this case, for a very good legal reason.
Oh, no, understand. That's why I'm asking these questions. So it is truly separate,
Yes.
not just another folder per se within another system, right?
No. And, we go as far as to even our paper records are under lock and key. We have something called the cage where we put paper records where it's completely separate and you cannot, others cannot get access to it, even for paper records and certainly not for the cannabis program. We have over 13,000 people that are currently registered in the cannabis program.
So to talk about the time allocation here, one, this shows tremendous fortitude on your part to be able to keep going. But I was thinking that if we could basically do this in a total of 3 hours, that we might work through lunch and just let people go before the snow got worse. That was a possibility. But it's starting to feel to me like we're going to need to take a lunch break at some point and come back. So that was to your point yesterday, Representative Tulersky. I actually remembered. So, and I'm going to have a bunch of questions on these little programs. Yes, sir.
Do you think we could, with 2 hours remaining, does anybody strongly object to trying to finish by 1? That gets us an extra hour, right?
Well, that was the proposal, but we're the ones that keep asking questions.
I get it. I'll try and be conscious of that, but
And I'm about to ask a bunch. So I'm as bad as I'm probably the worst. So I'm just going to tell you what my questions are and just simple little answers if you can. The Hospital Flex program, I've forgotten some of the details of it, other than I recall that this was a pretty cool program.
Correct.
So if you could just remind us of what that is. I also, on the therapeutic cannabis program, this is my 4th term, I keep asking the same question. Are we at risk because of the competition from recreational pot of having our therapeutic cannabis program, cave in because the alternatives are out there and cheaper? I'm worried about the long-term sustainability of that program. And then on the prescription drug monitoring, I'm curious what they do relative to the Prescription Drug Affordability Board. So
Great.
those
So
are my 3 questions.
I'll try and answer those sort of in backward order. The prescription drug monitoring program is not connected to the prescription affordability program. Those are 2 separate things. Prescription drug monitoring really is focused on opioids and stimulants and just monitoring how prescribers and providers tap into that data to see what other prescriptions an individual has. Totally separate. The question around therapeutic cannabis, around whether recreational pot or recreational cannabis is impacting that, certainly we believe so. So our alternative treatment centers, which are the retail environments that do the growing, production, selling, they will tell you that they are certainly feeling a hit because their product is more expensive, A, than the gray market, and B, what you can get in Massachusetts. They will also tell you, and we will tell you too, it's probably of higher quality because of the testing that we have on it and the nature that it is for medicinal use. And so there's a great deal of education that goes with it. So you would miss out, I envision this, if you were older than 65 years old and had cancer, whether or not you would want to go into a recreational shop somewhere in Lowell, or you would rather go into an ATC in New Hampshire that's focused on how do they provide the sort of products that could help someone who is going through chemotherapy. I think in general, folks that are going through some of those health conditions appreciate the alternative treatment centers we have here. The fact is it's expensive and it's all cash. So, insurance doesn't pay for it or anything. So regardless, flour, which is the vegetative part, whether you smoke it or somehow, or the products, the edibles, the vapor cartridges, those things are all expensive. So yes, they feel the impact of that market outside. The Flex program,
So I've encouraged them to, I forget the gentleman's name that has been running that for a while, but I've been encouraging them now for 3 or 4 terms to keep coming back to the legislature with proposals so that they can continue to be competitive. That's a program that I think we want to sustain regardless of what we do with recreational pot.
I appreciate that. And I think we've made some subtle change. We've made incremental changes over the past couple of years to help them along the way. Things like visiting patients. We're now going to allow for visiting patients from out of state to come and use those resources. We've made some internal changes again, but there hasn't been any sort of, we can't address the big gorilla, which is the recreational market that exists all around us.
Right. And then Hospital Flex.
And the Hospital Flex program, this is where it's 100% federal funds, and we work with our partners to do, to support those little hospitals for the most part, to do things like Medicare boot camp, where we pay for training so that those little hospitals can maximize revenues. Those are the pieces, we work with the hospitals and with the Hospital Association in order to ensure that they have the sort of technical support that they need so that they can keep their doors open.
Representative Hull.
Thank you. I'll be in the running for the number of questions, I guess. On the prescription monitoring, if
Yes.
I recall correctly, we were the prescriptions per person for opioids was something absurd, like 100 tablets per person in the state or something. This goes back a couple years. Are we still seeing that high a level of, has that dropped off?
So those numbers have gone down. I'm pulling out some data here. Even though I have my trusty computer. We have seen that the numbers have gone down of actually pills prescribed, which is great. We've also in the same seen the utilization from the providers and the pharmacists go up. That's exactly the crisscross that we want to see. That the utilization of the data is up. The number of prescriptions are going down to probably what's appropriate. The thing that we are most concerned about, not only in New Hampshire, but across the country, is the stimulants, on the other hand, are starting to creep back up, are going up, while as opioids are going down.
Okay. And then separate question, if HB 639 passes,
Yes.
right, and I believe it's gone through the House at this point, right? Senate is undecided where that goes. But if it does go forward, what happens to the therapeutic cannabis program as a whole? Does it become necessary, right? Is it now completely redundant?
Yeah. That's a really interesting question. So my recommendation would be that it doesn't become redundant, that there's always a program, there is value for having a program that's carved out for therapeutic needs. For a couple of reasons. One, around taxing it or any additional fees, that you keep it more affordable than you would with the recreational product, as well as that we keep the sort of limits around things like testing to make sure that those products are really safe, super safe, and that we are administering, but mainly for an affordability of the program for the participants. We would want to keep that separate. There are a couple of different options on the table. Either that stays within DHHS. There's been some thought that it could move if there was some sort of liquor plus cannabis commission. There's been some thought you throw it over there to administer. I think there are pros and cons with that.
Right. And I understand we're a budget driven group as opposed to a policy. I'm just asking because what do we do with the positions and
We have, historically, we put public health, put that program back together. It was a little bit like Humpty Dumpty when it first started. It had it was broken out into different sections across the department. Several bienniums ago, we actually moved it all to public health to make it coherent, to make sure it focused on meeting access to services, which is really what our job is, and to keep an eye on the laboratory testing of it.
So is there any way to right now, I believe it's cash, as you mentioned
Yes.
earlier. Is there any way to tie it back to insurance or not without risking disclosure of the individuals that are on there?
I think I think while it is still a federally scheduled, the insurance piece is off the table.
Thank you.
Okay. All right. 17, just again, because I've made all these slides, I'm going to make you look at them. Slide 17 is another piece that sits within that Bureau of something called our Health Professions Data Center. This is a project, again, under the radar. We don't talk about it very much, but we've worked with all of OPLC, with all of the medical boards or health-related boards, and we get information about providers. And this is just an example of that data where we look at the behavioral health professionals in the state. Almost, 42% are over 60 years old of psychiatrists in the state. And if you look down at that bottom row, we can see that anticipated reduction in capacity over the next 5 years is alarming. We're certainly losing over a quarter of our staff moving forward. And we use this data to support things like our SLRP program, my favorite acronym in all of public health, State Loan Repayment Program, to really focus on what professionals do we need to attract and retain in the state of New Hampshire, so that we have equitable access across the state.
So this data is counterintuitive to me. You've got older people in psychiatry than you do in psychology as a percentage, but we're expecting to have a higher reduction in capacity of the younger population of psychologists than the older population of psychiatrists.
Yeah, I think it has something to do with also the numbers in there. It is counterintuitive, but it gives you that we have fewer psychiatrists to begin with. Again, those are medical professionals with advanced training than even say your psychologist. Certainly more advanced training than your nurse NPs, your psych NPs.
So obviously that data drives a lot of our concern about our workforce issues.
Yes, and this is just meant to be an example of some of the data that we're looking for. We will have a report on the data professions data and the rural health at HHS Oversight in March. So that's a preview for more to come.
Psych, I did. Thank you. Psych NPs, what's the NP stand for?
Nurse practitioner, I'm sorry.
Thank you.
Slide 18, we're going to move into our Bureau of Public Health Protection. This is only our third of 8 bureaus. I'm trying to go fast. A significant amount of our regulatory programs sit within the Bureau of Public Health Protection. In this is included our food protection, radiological health, lead poisoning prevention. You will see that in this particular bureau, there's a lot of fees. So things like radiological health is supported by the fees that we gather to go inspect things like mammography machines. Those things are fairly self-funded. As I noted earlier, with food protection, by statute, we're only allowed to keep $300,000 of the fees that we generate. The rest have to be funded by the general fund. Lead poisoning, supported by both general funds and federal funds, as a result of a lot of interest over the past bienniums in reducing lead poisoning among our kiddos. So we can take any questions in any of those areas if you'd like, or not. I can go to slide 20.
I have a question on line 20. I know that to some extent we're taking federal money and we're creating a mobile service to do coronavirus injections. And I'm just curious if maybe that would be an opportunity to leverage some of that federal money to help us improve accessibility to lead poisoning testing in kids.
That is a very interesting idea that I'd have to think more about.
Okay.
Okay. Thank you.
So,
Representative Hull,
thank you. So,
would you like a gavel down there? Would that help?
absolutely not. Bottom of page 18, right? 12 positions, and oh, thank you. And it looks like this continues over to the bottom of page 959, right? We're spending $2.2 million per year on lead prevention and testing. How much of that is kits and how much of that is just overhead and administering and
Sure. So in the governor's budget on page 958 at the bottom, you'll see in state fiscal year 24, and just to note the increase in personnel, there, we actually moved a position from 7936 into this. So you will see 800,000 there. You'll see with benefits, it's about $1.2 million in personnel related costs. We do have a contract line, but Tricia, I don't know if you want to speak to the delivery of services and what those personnel are providing.
Sure. So in our program, we have a number of things that pays for. So primarily it pays for nurse case management. We have we have some federal funds. We also use some general funds. One of the things that you may recall is over time we have lowered something that's called the action level for when we take action, when we support families. That comes in two ways. One, there's nurse case management that comes with that lower level. And then on the other side is the environmental side where we go out and test, especially in rental homes. The other piece that we have used some of the additional general funds is to support individuals, both landlords and primary homeowners, so that they can have access to resources to remediate when lead is found in their house. And so that is balanced with some funds that are in HUD to be able to provide some loans and to provide some grants for remediation. So it's a mix of a lot of different things in that line. So we have nurse case management, we have basic education. One of the things I handed out to you, if you want to move, I have 5 of these, you can fight over them. We have new baby board books that one of our staff actually wrote, and this is sort of a national thing right now about healthy, free, lead-free me, happy, healthy, lead-free me. And we give these out in all the pediatrician offices. So if you have a baby in your life or someone who has a baby, make sure that they have that. And it's one of the ways that we try to communicate around the importance of lead screening.
It was nice that somebody wrote it so that we could understand it.
I could do story time next, but I think we're short on time.
So
Great.
I'm just struggling with, right, the contracted program services go down by north of $600,000 in the biennium, yet the department goes up by 400. So there's a net $1 million difference between, right, in lines 102 in total between last budget and this budget.
It's class 74?
Oh, wait a minute.
Okay.
Got it.
Okay.
Right. So if you look at class 102, many of those funds are being shifted up to class 74. The reason for that is we are required to identify whether any award that we provide that's federal dollars is a subrecipient, which would be reflected in class 74, or a contractor as defined by 2 CFR 200-331. And you'll see throughout these accounts, you'll see a number of those movements where we're shifting funds from 102 to 74, where originally we thought they were a contractor. The easiest way to think about a contractor under the federal definition is they're providing services either directly to the department or we have primary control over those activities. A subrecipient is typically where an organization, a contracted organization, is providing services on behalf of the department. They're in charge of more of the programmatic details. They may be conducting eligibility determinations as well, where essentially they have more control over the program and they're providing those directly to clients or individuals.
So I'm just trying to figure out, right, as we go through, right, equipment replacement goes up, almost doubles between the last biennium and this biennium. The costs are 10% plus, actually closer to 15% round numbers between last biennium and this biennium for total budget. So just where
So you're asking, okay, what are the increases? So one of the increases is the movement of that one position
Yep.
from 7936.
Okay.
You'll also see an increase in class 50, where the governor's recommended budget has included funding for additional temporary positions as well. That also has a net impact on the benefits line. Let me see here, some quick back of the envelope math. There's a slight increase in out-of-state travel, and some other slight increases, but those personnel lines are the key drivers, the movement and the additional
Right.
dollars for temporary positions.
And if I can add, those people are because we lowered that action level. And then quite frankly, we were, I never want to say I'm thankful for the pandemic, but those lower screening, we were certainly prepared that we were going to have a much greater increase in kids that had elevated lead screens that we needed to do something about. But that lowering came right at the pandemic when we also had a dip in the number of kids who were screened. So we've sort of slow rolled into this, but as more kids get screened, we're going to have increased work. So I can move on to slide 20. Again, just some visual. Fewer kids have been being screened. We anticipate that that's going to go up. These numbers are from 2021.
You almost got to 20. On 19,
Ugh.
there, well, I'm just curious because I'm looking at page 960 on the budget book, and this is where you begin to talk about EPH tracking.
Yes.
Also on this page is climate change adaptation, where there was money in the current budget that looks like it's all zeroed out.
Yes.
Where's that money now?
Sure. So, environmental public health tracking, it's a horrible name if you're worried about people tracking you, but it's really just looking at environmental public health data. So I just want to be clear about that. The climate change adaptation was a federal grant that we had received in this current biennium. We no longer will receive that grant in the upcoming biennium.
Good. We solved the problem. That's great.
We've
right.
solved
Go
climate.
ahead. It was just meant to be a joke. Go ahead.
Nothing else I need to add to that. Thank you.
No. Yeah.
So again, slide 20, just the data around lead, fewer screens. We need to get those screening numbers back up. As we get those screening numbers up, we're going to need those people to take care of the kiddos. That's just one of the takeaways from the past 2 years.
Mr. Chair. Thank you. So just remind me, where did we move? What are the new values for lead screening? I was out for 4 years. I didn't keep track.
Sure. So I think if you look on, I've got stuff popping up on here. We have, if you really look in at that data, and I'm trying to.
Yeah, what was it and what is the current
It
value?
has moved, and I'm going to keep, because I'm going to show my age, because it was at one time 10, it moved down to 7.5, and we are down now at 5. And
Is this in micrograms per liter?
Yes, deciliter. So we are moving down, and I think you can see that in there. On July 21, in July 1, 2021, it was lowered from 7.5 to 5, and for children 72 months and younger.
So it has gone from 10 down to 5 over what period of time? total?
Over more than a decade. It was at 7.5, certainly for a number of sort of the mid 2010s. It was at 7.5. I don't remember when we
Okay,
made that
thank you.
change. All right. So the next slide is around food protection. You've been hearing me talk a lot about food. I love the food program because it never really gets a lot of airtime. It is one of the oldest things we do in public health. When I showed you this book right here, one of the main things it talks about is food adulteration and food safety and testing milk. That, you know, like, so for over 100 years, this has been what we've been doing. We license and inspect over 5,000 establishments. We also do things like with shellfish to make sure when you're having raw oysters, you don't get sick and die, and food and beverage manufacturers. One of the things that we would like to highlight in here is that we do have a prioritized need in this area for overtime expenses. I think that the governor's budget may have zeroed out our overtime, perhaps inadvertently. We need overtime in this place, especially when we think about inspectors that are highly trained, like our milk inspectors.
So would you do me a favor? Tell me the page number and the line item and how much you think you need.
So if you turn to page 954, and it's class 18, it's at the bottom of page 954. In the agency's original budget submission, we had included $10,000 of overtime in each year. We had also submitted an additional prioritized need, which was not funded, for $15,000.
So that would have been 25,000?
It would have been 25,000 total. And the reason that we're asking for that is because on an annual basis, we have exceeded our $10,000 on a pretty regular basis by a significant amount, and it's always required transferred. So we're requesting this amount to reflect what is closer to the actual cost that we incur each year.
So any amount here would also be subject to the 10% pay raise and would also be subject to additional benefits.
Yes.
So even if it was $10,000,
It
it's
would not be enough.
probably more like 19,000.
Yes, we need at a minimum $25,000 in here. You know, and just to give you color behind that, we have 2 major milk inspectors, which is why I keep talking about it. One of them is on an extended medical leave. We have 1 milk inspector to make sure that all milk that is sold outside, it needs to be blessed by our staff before for federal law before it can go to interstate commerce. So we've been working someone, and we've maxed out their comp time and we've aired into like Federal Labor Standards Act problems. We need overtime.
So Representative Nordgren, I'm just open to asking Mr. Ripple to keep track of this, and this could be one of our agreed upon plus ups if you would agree. Yeah. And because I'm cheap, I would just throw 20 at it, knowing that it's going to be much more than 20 by the time you do 10% pay raise and benefits. And so could we keep track of 20 for that?
Sure.
Thank you. Representative Hull.
Looking at page 955 for this department, right? It looks like there's also a request to go from 14 to 16 as 2 additional people. Are they moving over from a different department, or is this unfilled positions?
Sure.
I think
Yeah.
these are conversions.
Yeah, so on page 955, you'll see the class 50, the 105 being zeroed out. The 2 temporary positions that are there are being converted, and that's the increase,
Thank you.
of course.
Great. So we can jump to slide 22. Oh,
Just kind of a newbie question here is, you know, obviously we have a lot of staff openings, which tends to drive overtime to higher numbers. Would we expect the same kind of overtime numbers if we were fully staffed based on the budget?
certainly being fully staffed would be helpful. This is not an area where we have massive openings right now. What's also driving this is we have an increased number of licensees in the community, and it's also seasonal. So it's not, so if you think about the summertime where we have food trucks and boardwalk facilities and all sorts of things that pop up. So we tend to accumulate overtime seasonally, and then it pops back down. So I think overtime is sort of always going to be a part of the price of doing business in this work because of some of the ups and downs.
Thank you.
Great. So,
What opportunities are there for some level of self-assessment / self-inspection at, right? Instead of having employees actually go visit these, right? Having the various dairy farms do self-inspection, self-certification, and then increasing, let's say, maybe the penalties for falsifying data or anything like that, so that we're not doing this, that we're allowing the farms to manage themselves.
So thank you for that question, and it's something we can always continue to consider as we move forward. In this space, we are navigating between federal law and state law. So there are, again, we've talked a lot about milk. There's a lot of federal law and FDA regulations that we need to follow that we don't have choices around. So that requires someone to come in and take a look at it. We've worked very collaboratively with our restaurant, so I think more about something like restaurants where we may have a little bit more room. We've prioritized high need or high risk restaurants over some of the lower risk restaurants as well, which is how we've tried to manage both time and energy. Great. So if we go to slide 22, I think that's about halfway through. We've spoken for a little over an hour and a half, so I might be on par. This is our Bureau of Family Health and Nutrition. As I noted earlier, this is the place where we've got tons of both small grants and big grants. There are also some things that are policies that you are sometimes interested in included in these in this bureau as well. This bureau has the most accounting units, so we can go through them, or you can just ask questions as you would like. One of the things I will note to you right off the top, On slide 22, the Teen Pregnancy Prevention Program, we will not be funding that in the next biennium. That was put in earlier in the agency phase, but it will be zeroed out going forward.
Representative Wallner?
Thank you. I was wondering, in the pregnancy risk monitoring system, what are you monitoring, and is one of them drug use?
Yes, so
during
thank you.
pregnancy?
That's a great question. So this is something called our PRAMS survey, Pregnancy Risk Monitoring something. So, and it is a survey that we send out to women who have just given birth. It's again, like all of our surveys, it's voluntary in nature, but people provide their information anonymized around what their experience was while pregnant and postpartum, as well as some of their health risks, which could include substance use, not only opioids, which, you know, probably has, people may not be as forthcoming with something like opioids, but one of the things that we've been tracking in here is cannabis use, which we find that people are pretty forthcoming about. So that's probably one of the best ways we have to generally trend the use of something like cannabis during pregnancy and postpartum.
Representative Mooney notes that there's still money in the forecasted budget.
Yes, because at the time of writing this, we thought we would be getting additional federal funds for the Teen Pregnancy Prevention Program. We are not applying for those federal funds.
So going forward, my plan is after we go through all of the presentations is I provide a series of change requests to the committee to consider. This would be one of those technical changes,
Understood. Thank you.
of course.
Thank you. The bottom of page 22 is our maternal and child health grant, that 5190. That has a lot of things in it, but I'll just draw your attention to it that is the, you know, as I said, it's been around since FDR and was modernized under Ronald Reagan and is one of the places that we actually have flexibility. It is a mix of, we have federal funds. We also have some general funds that are maintenance of effort that are attached to those. Much of the general funds that we use in maternal and child health is to support our federally qualified health centers for primary care and prenatal care.
Representative Hall?
Thank you. Not sure whether this is for Mr. Ripple or Mr. White, right? In terms of these changes, because we haven't seen HB2 update, sorry, HB1 in terms of this update as it works through, I guess there's, when do we get the next version of this with all the requested changes, the 10%?
Well, the 10% won't be in House Bill 1. It will be in House Bill 2, and you won't see it split out by department or accounting unit or anything like that. And I expect House Bill 2 to be ready for signature probably tomorrow.
Great. Thank you. We can move to slide 23, which are more accounting units in family and health. In here, I'll take note that one of our other prioritized needs that was not included in the governor's budget is in the 5260 account, which is the WIC Supplemental Nutrition Program. Again, a great program that we don't talk about enough. There is some legislation floating through around WIC Farmers Market. This is where if we were to move forward with WIC Farmers Market, we would ask for additional general funds to be placed in there. Some history on WIC Farmers Market. We used to have the program in the 1990s and early 2000s. We actually stopped it at that time because it was incredibly administratively burdensome in those years, because it used to be that you'd have to have like a paper coupon and you'd have to take that paper coupon to a farmer that accepted it, and it just didn't work well. Fast forward to today when our WIC participants have essentially what's a debit card, and they can swipe, and most of our farmers have a little square that they can accept a swipe. We think that the time is now to be able to get some matching funds so that we can access federal funds for the WIC Farmers Market.
So I want to talk about family planning.
Great.
That's on page 969. And so I have a few questions in this area. One, the actual expense of 22 relative to the adjusted authorization in 23, there's a substantial jump there. Could you just explain that jump?
So are you speaking of the fact that we expended fewer of our general funds in
Right.
22.
It goes from 755 to 2.817 million.
Right. So part of this, as we all know, we had budgeted to fund a number of family planning providers, 3 additional family planning providers, including Planned Parenthood of Northern New England, which was our largest provider and received a significant sum of funds from us. Those contracts were rejected by the council, and so we did not expend those dollars. We did expend dollars on the other 4 agencies that that have family planning services. Those agencies are in places like Amoskeag and Lamprey, are in community health centers.
So this authorized amount for the current year, is that likely to be spent, or because I don't believe those contracts were let still?
Yeah,
so-
we will likely in 23 not spend all that money, but what we're looking forward to do in the next biennium is to reallocate some of those general funds to the existing providers and also work with the community to see where else we can use those funds to ensure that we have access to reproductive health services that in a way in which that our council finds acceptable.
So one of the things we did with HB2, and I think there was some money put into HB1 for this, was to incentivize new vendors to step up and compete for these contracts. And I don't remember how much that was, whether it was $10,000 spiff or
Yeah, it's 5 figures.
yeah. So I understand that no one actually qualified to get that additional money.
Yes, no one qualified there was not
No one
interest or qualified.
tried,
Yeah,
right? That's what I think you're saying, is no one tried.
correct.
Okay. So if we were to double that, would that have an impact on those that may want to compete for it?
We are always happy to put out new proposals, new requests for proposals to see if there are additional providers that are interested in meeting the services that we have.
So doubling the incentive for a new provider could potentially help.
It wouldn't hurt.
Okay. So I represent Nordgren. One of the things I've submitted to Mr. Ripple is similar to the HB2 item in family planning that we did last year that I think we all had sort of a partisan difference on, was just being able to have that incentive pay so that new vendors who hadn't previously received family planning money would be incentivized to compete. So what I would like to do is to increase, double what we did last year, Mr. Ripple, and then we can discuss it later, in a week or two. You guys can tell me why you think I'm wrong, but that's one of the things I'd like us to discuss. And then Mr. Ripple, one of the HB2 items that was, I think, fairly controversial was related to, I'm going to say it was financial and physical separation. And I think we got rid of the physical separation and kept the financial separation. And we put that limitation in HB2. Does that language live on, or do we need to, if we wanted it to continue, we would have to add it to HB2 again?
I'll have to take a look at House Bill 2 from 2 years ago and see if it was for the biennium only or if it had a repeal date.
I don't recall a repeal date specifically in it,
Okay.
but I just don't. Some of the HB2 stuff is only for the budget term, and then some of it seems to be more perpetual, and I don't know the distinction.
I'll look it up now. If it doesn't say for the biennium only, and if it doesn't have a repeal date, then it would live on.
So, some aspects of it were chapter law and others were RSA.
See that, if I were smarter, that would mean something to me, because I've heard that term, probably 10 times in the last 2 years. So you want to turn your mic on?
It's not really relevant. Chapter law can live on too.
Okay. Did you have a question on this in this area?
Only
I'm
when you're done. Yes, but when you're done.
I'm done.
So regarding the federal dollars, I think they're a little off. I believe I can't, this is off the top of my head. I believe the Title X funding from the federal is $800K per year, but I could be wrong about that. But the difference between that, whatever that is, and the actual FY24, not the actual, but the budgeted FY24, is we were between two different terms. And so you're able to roll over. So that explains why the FY24 is substantially higher, because you're able to roll a bunch over into that and add it into the Title X. But I don't believe the FY25 should also have that extra money in there.
So I am looking to to Shelley back there. I think it was because some of that was rolled over. We are also expecting increased federal dollars under this federal administration.
That's already been allocated. I mean, this
The current one,
administration.
yes, this. So we can adjust this moving forward and make it closer to what the actual notice of award is. I don't have that notice of award number off the top of my head.
I get that, but I think you're missing my point. I'm not talking specifically about the award. I mean, I think it's lower than you think, but that doesn't really matter. But there's but it's definitely not two point whatever it is $1 million. Okay.
No.
The award's like 800K, I think, or something,
Yes.
maybe a little more. But that differential up to the 2 million is because of what you rolled over from the previous 3-year, whatever it is, period. But that should not show up in 25, right? That additional
Correct.
amount. Okay.
So,
We can work. I can work with Nathan and get that number closer if we want to have a change number.
So of the general funds for the coming year of 837,000 and the federal of 2 point something, is there a matching requirement there, or is this all separate? I
So
remember this to be
the-
separate.
This is a place where there could be additional clarity from the federal government. Is the nice way that I would say that. The federal government in the law says they will not pay for the entirety of the program. That is what it said. That is what the language says. They will
Would you
not
like me
pay
to
for.
read it?
Mhm. Yes, please. Thank you.
So the guidance that is available include financial support from sources other than Title X, as no grant may be made for an amount equal to 100% of the project's estimated costs.
There you go. That's what the feds tell us.
Okay, so there's a lot of numbers below 100% though. Yeah. So Representative Wallner, you had a question here?
Yes, could you, I think you already explained this to us once before, but could you go again, explain the difference between the grants for public assistance and contracts?
Absolutely. So there's subrecipient and contractor as defined by federal uniform guidance. I think contractor is an organization that we contract with, and this is where it gets confusing because I'm going to use contract in both terms. We contract with a contractor and they provide those services primarily to us. They're not making eligibility determinations. It may be more technical assistance. It could be like some kind of public information initiative, something along those lines. Think many of our IT contracts versus a subrecipient. And our subrecipients are those organizations that we contract with that are providing services on behalf of the department. And so they have more programmatic control as defined within the contract, but they could be one of the key drivers within the federal guidance is, are they making eligibility determinations? And so we have to report on our subrecipients, and part of many of the changes that you're seeing here is partly cleanup to make sure that it's easier for us to track this information going forward. Because historically, sometimes when we budget under the contract line, we may or may not know at that point in time whether we're going to have a contractor or we're going to have a subrecipient. And sometimes you really have to dig into the details to make that determination and to make those strategic decisions about how you want to execute the objectives of that program.
And I'll just highlight, so the way that looks in family planning, we certainly have our family planning providers. That's one type of contract. And then we have a contract for our data system. And so that's the other type. So that's why you see both.
Yes.
I think I got it finally. Okay, thank you.
Thank you, Mr. Chair. So I guess, Nathan, is it possible with all of the changes that we're talking about because we're moving around potentially large sums of money. If this $2 million in 2025 under the federal funds is maybe off by more than $1 million, for you to either redline this book as is, I don't know if that's even an option. Can you take HB1 as the governor handed it to us and make the changes in real time on top of it so we can just replace the pages or provide it in some format that's similar?
Well, I was gonna say, Mr. Ripple might have the response to that in terms of the way it's handled.
I'm not sure. Is this something, Nathan, that you could address in terms of the department's
Yeah. So
technical changes?
yeah, so we have a standard change request form that has the year, it has every single class line, and then it has the requested change. So you'll see class 10 go from 100,000 to 200,000, and then it'll have the net impact. So we have those documents, and when we work on that change request, that makes it very clear as far as what's going where, what's increasing, what's decreasing.
So, Representative Irf, I'm going to look to you on this. As I remember, this is also complicated by the idea that the federal government will bypass the state altogether, and so we wouldn't see some of those monies that go directly to the abortion providers.
So that's a separate issue, and it's not specifically the abortion providers. It's specifically Planned Parenthood of Northern New England, and I'm pretty sure that they've not mistakenly included those here.
No.
There's another issue that's involved where we're between the way the federal government allocates these funds is in either 3-year or 5-year. I think we just went from a 3-year to a 5-year. And in between those two periods, if you have money left, and you can within a period you can roll the money forward, and between periods, if with a waiver you can roll it over a period. So we just came between these two periods, and between 23 and 24, as I understand it. So they got the waiver and they bounced it over into 24. Is the way I understand it. If I'm unless I'm
You are
mistaken.
100% correct.
So that explains the 2 million is basically whatever the basic Title 10 would have been for the state of New Hampshire, which I think is around 800K, but I could be wrong. Plus that, plus up. So 25 then would only be the amount of the Title 10 funding. It shouldn't be the plus up as well. Although they'll still be able to roll the funds forward if they don't get spent in 24. That's just sort of how the system
Correct.
works.
That's correct. Thank you. Great. Also, not only is family planning fun and exciting on this page, but we also have our home visiting grant, which is the last of the 3 things I'm going to come begging for a prioritized need. Our home visiting program this home visiting program is federally funded, called the Maternal Infant Early Childhood Home Visiting Program from the federal level. Locally, this is something called Healthy Families New Hampshire or Healthy Families America. Incredibly important preventative program, really looking at reducing the number of adverse childhood experiences and, more importantly, supporting young families. In the coming biennium, we are going to have an opportunity to receive additional funds for home visiting to serve more families. This has been very successful. We're maxed out in the number of families we can serve, but moving forward, we will have to have a match to go with that. So we are looking for around $525,000 per year as a match so that we can serve additional families in the coming year. I know that's a lot to consider now, but I just wanted to put it out into the ether as our third and final prioritized need.
Representative Wallner?
So I would like to follow in your footsteps and ask that Mr. Ripple put this on our list of things to come back to, this $525,000 for a match.
And if I may just make a point of clarity, just so you're not seeing different numbers, in our original agency request, this was 1.25 million each year. But we've received new information since that point in time. So that's why you will see a discrepancy between the 525 and the 1.25.
So we're asking for less money
And is this 525 for the biennium?
each year,
Each year.
annually.
Thank you. Yes.
Just quick.
Mr. Ripple, it looked like you were going to say something earlier. Did you see something?
No, I will add that to the list.
Okay, if you see something, say something.
Right.
Somewhere over
We-
here?
Yeah, just of the additional 525, most of this budget is for grants for public assistance and relief, would you see it still going in there? And
Correct.
could you talk about what kind of thing that is?
Sure. So if you wanted to scoot all the way to slide 28, there's a little more information there. This program works with young families from usually prenatal to age 3, although we have some additional DCYF money we've added to that to serve 3 to 5-year-olds who are at elevated risk for child abuse. So not everybody, but we've been able to extend the program a little bit for those even at a higher risk. But in general, we provide voluntary home visiting services, which provide prenatal education, child development education, screening for maternal depression, really helping families get connected to places like their family resource center so that they are supported in the community. With what we've learned, one of the million things we've learned during the pandemic is the need for social connection. And this is a program that supports that sort of social connection. And ultimately, the outcomes are reduced child abuse rates, increased access to things like preventative screenings for kids. One of my favorite things is we see a decrease in the number of kids who use the emergency department for unintentional injuries. We all around supporting parents' ability to parent to their best ability.
Is the Healthy Families of America the contractor that you're working with?
The Healthy Families America is the name of the curriculum that we use. So it is an evidence-based curriculum that we put the money out into the communities. Each of those places that are like family resource centers that participate become accredited through that entity, Healthy Families America. So, a small amount of the money goes back to Healthy Families America, but in general, the contract money goes into the community to support home visitors to meet families where they are.
Do you foresee having more contractors or having bigger contracts? with
We
your existing
we
contractors?
anticipate having the same number of contractors. Likely, we have full statewide coverage by county. We've got a contractor. What the additional funds would enable us to do is 2 things. One, serve more families. So they would have additional staffing costs so that they could serve more families. We've also recognized that, and federally we've recognized that the way we've funded these has been pretty low. And so the workforce challenge is we need to actually have a little extra money in the game to get the staff to do the work. So this would enable them to give a little bit more of a bump up so that people could have something closer to a livable wage in order to do this really important community-based work.
So you're saying you're underserved right now because of, and do you have an idea of what percentage of newborns are not being offered?
You know what, I can come back to you with that number. Right now, the program is focused on Medicaid eligible families. So again, of all the families, that's still 24% of families right there, rather than all. There is just to put it out there is a separate provision in the Senate's Momnibus in that bill that would actually create some work to say, how could you increase home visiting to families beyond Medicaid eligible? So that's a separate line of work that'll happen over there. But for the Medicaid eligible families, we're nowhere near the capacity that we could be.
Thank you.
Representative Wallner.
I just wondered how many additional families you thought
I could probably give that to you after lunch. I know it is in one of my notes here. I can pull it right up.
Great. Thanks.
Thank you. All right, great. So we can move to the other items in family and nutrition is on slide 25. There's a number of activities there if you have interest, and on 26 as well. 26 sort of shows that we go to the upper end with our senior nutrition program. So not only are we talking about moms and kids, but we're also talking about seniors.
Share. Page 977, right? Grants for public assistance, line 74, right? We're going from 0 to 3.2 million.
Is this because it was in 102?
Yeah. So on page 977, the class 74 you're referring to, grants for public assistance relief, you are seeing some movement of the from the class 102 to increase that.
Okay.
Just moving around. Of note, we will be at any day now, we're expecting a new, what's called a NOFO, a Notice of Funding Opportunity, for the next iteration of the Opioid Data to Action Program, this opioid surveillance. So we think this is where we're going to land, but we will have a new award imminently.
DOJ transfer.
And there's DOJ money in there. Okay. All right, so we can go, slide 27 just tells you more about WIC. You've already heard me saying the praises of WIC, that we would love to support WIC Farmers Market. Slide 28 talks a little bit about a home visiting, and this is the place that we would like to have additional general fund, not even additional, but to have general funds in order to serve more families. We can go into infectious disease, which is also everyone's favorite thing to
Excuse
talk
me,
about.
Ms. Tilly, just
Representative Mooney?
one
Yes.
question here. With regards to that, Healthy Families in America, where specifically, what page and line item in the budget is that
I will
discussion
tell
centered
you.
around? Thank you.
Let me just go back to that. 971. Thank you. So we will go to slide 29, which is infectious disease.
I think Representative Mooney is just
Oh, I'm
still
so
trying to track. So
971 page number in the line.
That's 74.
Yeah,
It's class 74.
yes. Thank you.
and then are you still on slide 28 of the colors?
Slide 28 is just more information about home visiting. I'm trying to.
I'm curious
quick.
because we have another postpartum bill coming around. That second bullet jumps out at me.
Yes.
It says that, basically, this 8-week mark after delivery is a major demarcation point. And right now, I believe the authorization is for 2 months. So is it right to assume that nearly 20% of our moms lose their eligibility before they've even had a chance to get their visit, or do their eligibility continue until we do at least one visit?
Their eligibility, there is a number of postpartum individuals that lose their eligibility 8 weeks, which is why we've had this as a data point for us to try and get them in before they lose their eligibility. There's also physiological reasons why you want to have moms in there probably at 2, 6, and 8 weeks, that those are really important times physiologically and clinically that you need to get your eyes on newly delivered moms. So again, this is a holdover of a policy choice that we've made at a federal level where we lose Medicaid. So we've had a push in some of our supportive programs to make sure moms get to those healthcare appointments. And we know this, Public Health has been working with Medicaid to ensure that 12-month postpartum care, because we know really at 8 weeks, think about babies, that's when they start not sleeping through the night. Moms are under incredible amount of stress. And what we've seen in our maternal mortality, as you know, Representative Edwards, we've seen the increased risk for overdose and suicide post 8 weeks. So getting expanded Medicaid or getting Medicaid coverage postpartum is incredibly important. We have managed this with the current system by trying to get as many moms into care as possible by 8 weeks.
Did you have a question, Representative Holt?
I do. Sorry, this is a naive question. So I see 81% on page 28, right, of home visited moms. I'm reading that or interpreting that to mean, right, 81% of the new mothers had someone stop at their door to visit them at home, or is that
Yeah.
to just having an interaction with them, whether it's in a pediatrician's office or somewhere else?
So thank you for the opportunity to clarify that. What that is saying is, of the people that participate in the home visiting program, so again, a small number of the overall Medicaid population, of that group, 81% of that group gets to their doctor's office by 8 weeks. Is that helpful? That's very helpful. Thank you.
So
right.
are you about to get to 29? Are
I
you?
am,
Oh,
whenever you're ready.
No, okay, so this is a good time checkpoint. Representative Nordgren, it's noon now. Would you like us to continue as we're doing to see how far we can get? And we'll postpone a lunch decision for another 30 minutes or so to see how far we get, or what's your pleasure? Okay, so how are you doing?
I can go forever.
You seem like you're able to talk.
There are many questions
Do you
to
need
answer.
more water or something? Can we get you something?
I'm good
All
so
right,
far.
all right. Representative Hull.
Thank you, Mr. Chair. Page 981, I'm just looking at the summary for all of this, if we can go there. Right, we're going from 28 million and 34 to 39 for each year in the biennium. It looks like most of that is coming out of federal, but I don't understand where this other funds is jumping up by 1.6, $1.8 million or something, if I got my numbers right. Almost 2 million.
So other funds can include a number of things in here. That is some of our rebate dollars, I believe, as well as things like our newborn screening program, where for every baby that is born in the state, the hospitals purchase something called a filter paper, which is where you put the screening test on. That's how we fund that. Those are another piece that adds into that other funds.
So are these coming from other parts within DHHS, or is this from private providers in terms of
These
some
could come from
reimbursement?
separate, again, rebates come from the food in WIC. When we enter into a contract like with a formula vendor, we get a rebate based on the number of food items that we sell. We then turn that money back into the program to support the program. Same thing with the newborn screening, that those dollars come from the hospitals, and then we self-sustain the program from those fees. So they're neither state nor federal dollars.
So within the above lines, where do I find that 1.8 million, right? The general funds is pretty level funded on page 981. It's reasonably similar to 2023. However, it is different than 2022, and maybe that's part of the variance. I don't know, but there's a huge jump in the other funds.
We would have to go back through and look through each account.
Yeah.
Just to identify what the discrepancies are. We can certainly follow up with that information.
Yeah. Thank you.
Mr. Chair, I think one of them might be just the WIC rebate, which went
Yeah.
from 2.6 to 4 million. The amount of rebates you're anticipating, so.
Okay. If, with the pleasure of the chair, I can fill in a couple of questions from my trusty folks in the back who've been helpful to find answers while I've been up here. So you asked for the number of suicides. I'm pleased to know that the number I was about to spit out is correct. 2020, there was 234 suicides, 2021, 223, 2022, 242. So I was about to say around 200. That's the number. Home visiting number in 2022, we served 522 adults with 306 children in 344 households. So again, tiny numbers when we consider the entire Medicaid population. Everyone could benefit from home visiting.
Go ahead.
And if I may, just to clarify, Representative Hull, so on page 981, you see the other funds there in 22, and then you see the adjusted authorized in 23. So those are the funds that we actually received. So we probably, and I can look this up real quick, but we probably budgeted at a much higher rate. So that's what we actually were able to bring in.
And I think to add to the, again, sort of the color commentary, over time, especially with WIC rebates, sometimes we've had to accept money because we were budgeted too low. So we've just budgeted it high so that we don't have to keep coming back to you at fiscal over and over again.
Thank you for that.
As long as I've been doing time checks, we have a couple of people in the audience back here. Did you intend at some point to speak or want to speak, or what brings you in today? Okay, so they're with you.
Yeah,
Yes.
they're with us.
Yeah.
Okay.
Yes.
They're just us.
I just didn't know if anyone was selling tickets to this. This is pretty.
No one else is interested in this.
Yeah, all right, let's keep going.
Okay, great. So I think we're down to slide 29, which is infectious disease, and I lost my spot. So again, our Bureau of Infectious Disease, fewer accounting units in here than the previous bureau that we just had. Ryan White is the work that we do to support people with HIV. Those pharmaceutical rebates are again another other set of funds that are associated with HIV care. Disease control is sort of our larger disease item, mosquito control fund, and then if you go to the second page, that's where we look at more of our vaccine and immunization related funds, as well as STD and HIV prevention. Any questions?
I was wondering where Lyme disease might fit in.
So
And
that would generally fall into disease control and the work that we do within our larger, that's the bigger catch-all of some of our federal grants and some of our programs, and that's where Lyme disease, as we know, Lyme disease is a reportable condition. We have about 30 reportable conditions that all need to be sent to the Division of Public Health Services, and that is one. We certainly have seen those numbers go up over time. Thank you.
a follow-up?
Go ahead.
It's just I'm seeing, you know, some that yeah, it does seem to be growing, and also I'm not sure best practices in terms of early treatment shortly after diagnosis per CDC guidelines is being properly followed, you know,
Yes.
including antibiotics like doxycycline, and so just thought I would bring that up during this section. So, and
Thank
if you
you.
have any comments on that, I'd appreciate
Yeah,
it.
no, I mean, I think we are seeing this with all the arboviral viruses that we're seeing. So whether it's Lyme disease or other tick-borne or mosquito-borne illness, we're going to continue to see those go up. As our weather changes, we will see more of these diseases. We're just having longer springs. We have less hard winters, even though it's, you know, the individual weather may not change, but as we know, climate has certainly changed. And so we are prepared to continue to see that those go up. As we move forward, and we work with our clinicians to help with those make sure they're following the appropriate guidelines.
So year 6, here's my favorite question on STDs. What are we going to do in this budget cycle that we've not yet done to make sure that public awareness is increased around the prevalence and trends in STDs?
Thank you. As many in this room know, and certainly the people who are sitting behind me know, I love to talk about STDs. It's one of, you know, when I'm not talking about home visiting, I'll just talk about chlamydia until the cows come home. On slides 31 and 32, you'll see that we have this increase in gonorrhea and syphilis. We have actually seen a little decrease in chlamydia, but I think that's more a question of screening because the physical symptoms of that don't drive you to the doctor in the same way that the physical symptoms of gonorrhea and syphilis get you to the doctor real fast. But chlamydia is certainly a concern because over time, especially for women, that can lead to decreased fertility. It's a big sort of silent issue that we want people to address. To your question, I think we have more bandwidth to address this. We are working next week actually to make sure that our data is in a much more transparent place. We currently do monthly reports. You can find them online, but they're static. And they look a little bit like, you know, the slide 32, great information, but it's not on our DHHS data portal. Over the next biennium, we're going to move that data to be much more dynamic and available. I think we need to figure out in terms of prevention, one of the sad things that's happened with the reduction of family planning programs that we can fund. Part of their work was also to really do education around STDs, and we just have fewer people contracted to do that work. So we're going to have to find new ways to make sure that individuals, especially young adults, know to come in and get screened.
Well, actually, we have more money to fund the family planning programs. We have fewer contractors willing to take the money.
We have been able
Slight
to have,
difference in semantics.
I would just put a finer point on it that our executive council has rejected some contracts that were bid appropriately.
I don't disagree. Okay, I do want us to do more to push this information out to the people that might get scared and behave. So
I think that's great. And quite frankly, we have the bandwidth to do that as we move forward. You know, knock on wood, we have the bandwidth to do that. As we've discussed, the same people who do disease investigation for STDs have been the people who have been on the front lines of COVID. As we've pulled back from COVID, we have more space to
That
do
makes
this.
sense. Representative Hull?
Thank you. You're still ahead of me. I'm still on page 986 coming through vaccinations.
Okay,
So sorry to take you back.
it's fine.
In 2022, we had 17.5 million spent on vaccinations. There's an estimated 16 for 23, 24, and 25. A nice round number. I have no problem with round number estimates. But where were we before COVID? Because I would suspect that $17 million also had a chunk of COVID stuff tied in, or not?
No, COVID does not show up in there.
Okay. So then why are we estimating something at $1.5 million less than we spent in 2022?
This is a revolving
986.
fund. And this is our best estimate. Because this is a revolving fund, we don't come back through fiscal for these funds, just given the unique nature of it based on how it's established within RSA. So that is our best estimate at this point in time, and there's fluctuations from year to year.
Okay. And then, so when it says other, right, source of funds, it falls under revolving funds, but it must come out of the general at some point? So
No,
where is this coming from?
these are truly other funds. The way New Hampshire ensures that all children, regardless of insurer, has access to all recommended childhood vaccines is that the HMOs and the commercial providers all come together and essentially give us the money to buy the vaccines. We buy the vaccines with those funds. So again, it's through the insurers. We come together, we buy the vaccines, we distribute it. It's just a different way to ensure that we capture all kids and no one falls through the cracks with recommended childhood vaccines.
Okay, thank you.
Great. I think that's everything in infectious disease. You can learn more about chlamydia and gonorrhea on your own time. We can go into slide 33, which is our laboratory as well. This has 2 pages, some larger funds and a couple of smaller ones, but these are the funds that support all work at our public health lab. And so that includes both microbiology, chemistry, and virology. So everything from rabies to gonorrhea, in there, as well as chemistry around water lab. We've certainly heard in the news recently around the increased detection of radon in water. Our water lab does a great job of testing private home well owners that want to have their water tested, as well as working with environmental services on some of the other water systems that need to be tested.
Does this also include any money spent on laboratory work to support law enforcement?
No. So the Department of Safety has their own laboratory that's sometimes called the Tox Lab that really does a lot of the work that they do, especially around opioids or substances and other pieces. We work closely with them. We partner with them where needed. And what we do in public health, fundamentally with regard to opioids, is we have some new opioid federal money that we're using to be able to do greater testing on not only the opioid themselves, but sort of the human element of to get an understanding of what's, especially with poly drug use, what's in people's systems. So we do a little bit in that space, but very little. But the Department of Safety has its own lab.
So a few years ago, there were some sensational articles, news stories about fraud in laboratories, government-run laboratories, to where they weren't doing the sampling or they were faking the results. And I'm just curious, not accusing anyone, but I'm just curious, do we have a systematic way of doing like an independent audit just to kind of, maintain assurance that we're running our labs properly? Is that all CLIA, or is that?
So it's significantly CLIA. We have a very robust CLIA and quality improvement program within the lab where we're doing sampling, constant sampling to make sure that we're getting consistent results. We have, in fact, we just passed a contract through Governor and Council last week around the system that we use to collect all that data and make sure that our quality improvement and a quality assurance program is working well. I am 100% confident in the work that happens within our laboratory. We have an extraordinary group of people that are work at the highest integrity and standards to make sure that what we're doing is correct. We use other laboratories to sort of to test to make sure, in layman's term, if I get this particular result, does that other laboratory also get the same result, to make sure that we have quality assurance?
I do. Page 991. So I'm looking at the total for this department. I can see in section 59, right, we're going from roughly $500,000 a year to 800. That's a $600,000 change over the biennium, but I'm not sure where I'm quickly seeing effectively a $1.5 million change over an average of 2023, right? 2023 was a 3.02 million, and we're up to 3.7 and 3.8.
So I think for first, and I will answer all your questions. First, I think it's important to remember that the numbers that you're looking at for 2022, 2023 are not what was budgeted. 22 is the actual expense, and there's a variety of factors that feed into that. The adjusted authorized is what was budgeted plus any fiscal or other carry forward items. The class 50, the temporary, or sorry, excuse me, class 59, the temporary full-time, we did add, I believe it was 5 additional temporary positions, I believe, to meet the continued increased workload. And then you will also see an increase in the contract line of almost $200,000 there as well. I don't know, do you know what the contract was?
I can't remember off the top of my head which of the contracts it was.
And I can follow up with that information.
So in terms of the laboratory testing, is this supporting some of the things like the wastewater testing?
Yes.
Okay.
Yes, it is.
So in terms of efficacy of testing wastewater, is that a good place to be putting 5 additional people?
I don't think 5 additional people are going directly to wastewater. In fact, I can think of 1 that is going to wastewater.
So-
And in terms of efficacy, we think that this is a place, while we're using it for COVID today, we're basically cutting our teeth on the COVID work. But our folks in the laboratory, our PhDs and our doctors there, are really anticipating that moving forward, this is going to be an area that we see more growth in. We certainly saw in New York State where they found a pocket of polio within a community using wastewater testing. So these are methodologies that we think are going to be important moving forward, and we can get it right now as we look at COVID. Thank you. All right. You can see I added some additional data there on slides 35 and 36 that talks a little bit both about our water testing lab, a little bit of biomonitoring. That's a program where we've been specifically thinking about the elements that end up in your body, those environmental contaminants. Food, also, we do a lot of testing of food and our food emergency response, both from a routine testing of things like shellfish. We also have to have capabilities in case there's a public health emergency where someone intentionally puts things in our food that should not be there. And so we need to maintain the capacity for that. There's a little bit of information about wastewater testing on slide 36. So speaking of emergencies, we can go into slide 37 if you would like. This is our new Bureau of Emergency Preparedness, Response and Recovery. We call it EPR. It's my favorite name of a bureau, the EPR Bureau. This bureau came into our budget in the last biennium. It used to be, the Emergency Services Unit used to be underneath the Commissioner's Office a biennium ago. It was moved into public health during the pandemic, really to improve the coordination. We've been working well, and also just the oversight, because so much of their work is public health related, and especially during the pandemic. So we have particular federal funds in there that are all around ensuring that we're prepared for whatever comes next. In whether that's radiological or a virus. There's a fund in there called the Public Health Crisis Response. That is a generally funded account so that we can respond when there's something emergent that comes up. And so it's a small amount of money, but it allows us to act quickly. We use this, a little bit of this money, just actually a very little bit of the money this past year for monkeypox, for example, or mpox as it's now known, because the feds didn't get any money to us at all until now. In fact, we still haven't gotten any money to address mpox at all. So we were able to use this to activate some of our partners. And then finally, again, we have radiological emergency response where we use funds from Seabrook in some cases to make sure that we're ready in case there's something bad there.
So I want to pick at the public health emergency preparedness on budget book 1001. I see that of the 6 million, 90% of it is federal generally.
Yes.
Is our 500,000, is that a mandated match? Is that a minimum level of effort? Is
Yeah.
that a,
It's a mandated match,
and it's a 10% match?
10%.
Okay. All right.
Thank you.
And so
And
is there an upper limit to what they're willing to match? If we put another 100,000 in there, would they
they would be
increase
more,
the?
we would all be very happy. I'm not particularly concerned about what the
I'm not
feds would
saying we
think.
would do it. I'm just asking.
I'm not saying that you would do it either. It would be incredibly helpful. This is a place where we actually run up against our federal grants. It looks like there's lots of money in there, but things like laboratory reagents, things like that are really expensive. And so this is a place where we're counting pennies to cover all our bases.
So it's just 23 people. That just seems like a whole lot of people to me, having worked in emergency response before.
So it's across a broad range of activities. So these include people in our infectious disease program that are ready to be activated. So it pays for some nurses, it pays for people in the laboratory. It also pays for the people who are true like emergency planners. So it's both doers and planners.
Representative Hull.
Thank you, Mr. Chair. So back to my earlier discussion on rents, leases, et cetera, right? This line is almost zeroed out relative to this. Is this space covered somewhere else, or is there a way for us to move over to this fund, right? Some portion of space at Hazen Drive, so it's better covered from the federal side.
So the rents, leases, it was $500 each year.
Right. That doesn't cover much space for 23 people. So I'm wondering whether there's a way to do that or not.
I don't believe that is renting any building. I think it's something smaller. It's photocopier.
We do $500 worth of
Okay.
paper.
So kind of along the lines where Representative Edwards was going, right? Is this a place where we would be prudent to actually incur a cost in terms of leased rented space that's currently covered elsewhere in DHHS? Somewhere these 23 people have to be working, and then bill it back through this department so there is a match so that we fund it appropriately.
So you don't necessarily see things like that here. We have a public assistance cost allocation plan that we utilize internally. It's a several hundred-page document. It's reviewed by the feds and approved. And we have a system in place where we leverage all those federal dollars. So you heard me talk earlier last week about our new business intelligence system that we've been working on, so that with a couple of clicks of a button, that I can quickly show you every account that's paid for out of a particular federal fund, federal fund or series of them. And so in that central account where we have those rents, leases included, we are leveraging as many federal dollars as we possibly can.
Representative Wallner, did you have a question?
So I just wanted to follow up on a question that you had about the match. Are there additional federal dollars available if we had more match?
Not to my understanding.
Okay, thank you.
Great. Thank you. So slide 39 just gives you a high-level overview of some of the things that we do within here around functioning. We work also very closely with Homeland Security. We are responsible for ESF 8, which is the housing and the health component, health and medical, as well as ESF 6, which is the housing components in the Homeland Security structure. We do, in good time, we've had nothing but training and real work over the pandemic. We've done all this work, but someday when we're not actually doing the work of responding to an emergency, we will get back to training for when there is a different emergency. It also covers things like REP, which is the radiological training, which we do every year as well. Because again, no one wants, we want to be prepared if something ever happened at Seabrook. Slide 40 puts us into our last bureau, which is great. I think we've flown right through here. Maybe flown isn't the word. This is our Bureau of Prevention and Wellness. Again, we broke out our population and community health services to that family side. This is the chronic disease side and prevention side. We have a number of federal grants in here. In fact, most of this bureau is 100% federally funded, big chunks of federal dollars, not as much general funds. And you can see through slides 40 and 41, the content area.
So I have a couple questions around the tobacco prevention on pages 1007 and 8. But on 1008, there's like $1 million of federal money and 600,000 in state funds. Is there a match in there?
No.
That-
Those were 600,000 that was dedicated to tobacco prevention several bienniums ago, and we have maintained that. And we use this primarily for a lot of our outreach to adolescents. These funds were specifically put in several years ago to address vaping. One of the best news stories is we've actually seen that number come down. We were at some point at ridiculously high rates in high school. We're starting to see that come down.
Okay, so this is level positions at 5.
Yes.
We're continuing 5. And then there's a fairly significant jump in the federal dollars for this, 150,000 on that basis, pretty substantial. What do they think they're getting for that extra? Do we know why they're plussing us up 150 some thousand, 160? You see what I'm saying? It's at 8. Wait, no. In 22, it was over $1 million. And so compared to 22, it's about the same. I let myself look at 23 for a second.
Right. Thank you.
All right. So let me ask you a different question. What are our metrics? This is one of the programs that has bugged me because I've talked to predecessors of mine who've they've been asking this for years and years and years. What are the metrics to know that this program is worthwhile?
Sure. So one of them is really utilization of the quit line that we do. One of the things that we've done, and I don't know exactly the percentages of this between general and federal, but we've added additional supports just for adolescents because the way in which you need coaching to stop your tobacco dependence, it looks very different if you're a 55-year-old woman who's smoked for 30 years versus a 18-year-old who's been vaping. So we've differentiated that way. So the metrics around uptake. We also are looking at, and you can see this in the budget briefing book if you want to look at, we are focusing on certain populations, specifically folks who have behavioral health issues. We know that they smoke at disproportionately higher levels. So we're working with those community mental health centers to try and see how we can reduce the number of active smokers in those populations. That's just a couple examples.
Do we know that there's a correlation between the money we spend in this program and actual changes in behavior? Or are we doing that on gut instinct?
I think that's the problem with all prevention services. It's very hard to draw an absolute straight line, which is why we measure both process and outcome. So we can measure how many people go to the quit line. That's a hard number. We know that we pushed that number. We did that through advertising, but quite frankly, the best way to get that is to work with our clinical partners to make sure that they've got it built into their EMRs, that if someone comes in as a smoker, they go through, there's some evidence base around how you get people to, the theories of change of how you think about stopping smoking, and that we can help people where they are and eventually move them into an evidence-based quit program. We know the expenses for tobacco use are extraordinary. You know, when we think about all healthcare, we talk about cancer, we talk about heart disease, we talk about asthma, COPD, emphysema. All those costs are on the way end, you know, way back end. You're going to get that in long-term care. You're going to get that in Medicare costs. So it's hard for us to show that. But we do know that if you start smoking, for example, before, you know, as a teen, you're much likely to keep smoking for the rest of your life.
So I believe all of that. I'm just still looking to see if there's a causation. So I'm going to tell you a 30-second story of why I have animus towards this program. I got 2 years ago, I got a call from a mom, and she was telling me how vital this program was to keep her son from smoking. And since there was a hiccup or something, a disruption in the program, she said that her son had started smoking. So she was saying that this program would have been vital, but it wasn't available. So when I kept talking to her, she was an RN at one of our academies, our academic academies up north, and her job was to take care of the health of all of those young students. But she couldn't control her own son. She said that the government program was essential for her to have an effective relationship with her own family. And that's the point where I thought, oh my God, is this government program replacing parenting or
Government programs never replace parenting, but they do help provide the conditions to make parenting easier. So it's the reason why we have policies that you cannot lawfully purchase cigarettes until you're 18 years old. That's part of, you know, that's a policy that this entity has put in place because we know that if you start smoking when you're younger, we know younger people than 18 have smoked, but we've essentially made it harder for them to do that. And that's the sort of thing that I think this program does, is it changes some social norms, especially around the work what we've done around vaping, which is saying, you know, big tobacco is lying to you. You're going to be addicted. This is vaping has nicotine in it, so it is addictive. That's the sort of work that we do that sets the conditions to help make it easier for parents to do their job.
all right, thank you, Representative Mooney.
Thank you, Mr. Chairman. Would you anticipate an increase in this particular budget section if House Bill 639, regulation and legalization of cannabis, passes?
That's a really interesting question. Thank you. We know, I don't, the answer is I don't know. We know things like vaping, you know, is normalized, especially when you're vaping both cannabis as well as tobacco. We want to minimize that to the best to our ability. It's interesting, to your point earlier, Representative Edwards, we saw the vaping numbers come down during the pandemic when more kids were at home more often, which is of interest. I don't know that there's a correlation there, but it's interesting to see that. As we have more access to a regulated commercial product of cannabis, it's hard. You know, we see that activity normalized in the household, much like when parents used to smoke, kids used to smoke as well. I imagine cannabis use in the home is going to drive use of other substances, but I don't know that for sure.
Representative Hull.
Thank you. How do you know that the numbers dropped during COVID? I'm curious what the data set that is.
Sure. So we have something called the Youth Risk Behavior Survey. It's called YRBS. It's a CDC-funded survey. It's done in our high schools, and we have 2021 data that was just released. We have not released it by school district yet, like it's hot off the presses. And we saw that in 2021, there was a dip in vaping. The other concerning thing was around the increase around some behavioral health issues. That's what we've been hearing in the media. The piece we're not hearing about yet, certainly in New Hampshire, is the dip in vaping and the dip of alcohol use to be.
So is there any correlation between that data and things like sales through the establishments that are the vaping sales in terms of gross revenue? I mean,
I don't know. I mean, it's hard because, again, if you're under 18, you're buying that illegally in some way, whether someone else is buying it for you or you're not being carded when you go in there. But I imagine that if you looked at the revenue, you might see that. But, you know, the number of the 16 to 18-year-olds, while it's important, certainly isn't the full number of people who were vaping. So, you know, more middle-aged people could have been vaping.
right. I'm just trying to understand the correlation. And was it because they were home and they weren't with their peers?
Yeah.
greater parental involvement, or is it supported by other things like sales of vaping products?
I think that is information that we've yet to fully uncover and look into. It's a great line of inquiry that we just have not had the time yet to do since the data just came out. We had been seeing, a 4-year pretty marked trend upwards of teen vaping, and we're now seeing, we're hoping we've gone over the hill and we're starting to go back in the right direction. What's causing that? We're going to have to find out more. Again, many of us can sort of imagine that kids were at home more and not with their peers, but that's a conjecture. I don't know that for sure. Done. 42 and 43, slides 42 and 43 just tell you the great work that we've done around chronic disease, worked with great partners like the YMCA to do things like diabetes self-management. Great program under the radar that we do. Slide 43 highlights some new work that we're doing with EMS in communities and hospitals called Mobile Integrated Health, where we're maximizing the use of EMS providers to be able to provide some care after people come out of the emergency room for a chronic disease, whether that was an asthma event or a diabetic event, and that we're helping them with that self-management so that there are fewer readmissions. This is really promising. We've just started this work in this past year, but it looks great. We're excited to see where it goes. And then on slide 44, that's just our last final plea for some of those prioritized needs to support families. So that's it.
So wait a second. You may have ended too quickly on 44. You're saying these are your priority needs.
Yes.
Why don't you just spend a moment to talk through these?
Sure.
What's going on here?
Sure. These are so as I noted, we have 3 prioritized needs in public health. One is the overtime for food. I didn't add that there. It feels technical in nature. We just need an overtime line that's manageable for food protection. What slide 44 really talks about is the combination of both home visiting and WIC. These are places where we put interventions with families that are most at need at really vulnerable times. We know if we think about WIC, we've going to see the unwind, as I'm sure Director Lipman has talked about, and other folks around the fewer SNAP benefits that are going to be available to families, fewer other hard concrete supports. We know that WIC is going to be more important now, certainly than it was in the past few years. And so we want to make sure that we have the opportunity that not only can they use their WIC benefit as it is right now for the grocery store, but that we could have an opportunity for them to leverage additional federal dollars to have extra access to fresh fruits and veggies through farmers market.
So I'm not seeing dollar amounts on here.
No.
Do you have intended targets that you'd
Yes.
like us to consider, and how will we know what those numbers are?
The original prioritized needs that we submitted, it was $300,000 of general funds in state fiscal year 24 and $300,000 in state fiscal year 25 as well.
And for home visiting, what we're asking for is less than the original request, which was 1.25 million. We're down to 525K per year, because we have better numbers to work with now. And then just the $25,000 in overtime. Those are the $3 figures.
Okay, and I notice on page 40 that we have a wise woman program, and I'm just wondering, can we find no wise men anywhere? A sexist would say. Representative Hull.
Thank you, Chairman. So, I'm looking, my background is in the medical diabetic domain. So I'm hypersensitive to that field. And in watching how COVID played out, unfortunately, a number of patients did not handle COVID well and didn't make it through. But we have seen long COVID impacting the endocrine system, impacting people, pushing them into the secondary diabetic market, right, for
Yes.
Either hemo or peritoneal dialysis. How do we get ahead of this and start talking about the importance of vitamin D? Maybe I was naive, but I did not realize, and I would consider myself rather well read, how valuable vitamin D was to address and help prevent some of the side effects, both long COVID as well as the other things. How do we get ahead of that now in terms of a budget priority? Most people are vitamin D deficient.
Yes.
We can't do anything. We're at the 40th latitude mark, right?
Yeah,
We half the year we don't have sun. So how do we start? What can the department do to better prepare our citizens? Because yes, we used to drink lots of vitamin D infused milk. Guess what? People aren't drinking as much dairy anymore, right? Especially when you get to the older populations. So there is no place to, right, in their typical diet to deal with this, yet it is really crucial to weathering various viruses. What can you do as a department, and how do we make sure that happens?
Sure. So I can say certainly within the bookends of what we have now, we work closely again with partners like you see on the slide with Granite YMCA to really focus on diabetes self-management. And in that is a focus on nutrition. And so I think that's a place that we can add additional information and support is around nutrition as well as physical movement. Those are the areas that we know regardless, certainly for whether you have pre-diabetes straight into whether you have more advanced disease, we know that just taking care of those two things, getting nutrition under control and getting your physical activity under control, we can help create better outcomes in the long term. So I think that that's a place that we can provide additional information. We're certainly going to always look to CDC and to our other clinical partners. And, I know just enough to be dangerous, but certainly, Dr. Ballard and Dr. Shan help us in those spaces. But nutrition is of paramount concern, and we do that through these localized self-management programs that have coaches to help people to work through their own individual issues. Thank you.
Representative Earth, did you have a question? No? No, Representative Tulorsky?
Thank you, Mr. Chairman. Thank you for taking my question. When you referred to $300,000 to meet a priority need, was that the nutrition ask?
Yes, that is the nutrition aspect.
Okay, thank you. A quick follow-up. There was a bill that I believe was defeated last week. I just was frantically looking on my phone to find the number, but I believe it had to do with expanding WIC access to
Yes.
farmers markets. Was that a similar program that
Yes.
you would have been interested in?
Yes. So essentially, there was certainly legislation that would have put that money into this budget. We know that for many reasons that didn't move through the House. We're still very interested in expanding access to fresh fruit and vegetable for the WIC population.
Thank you.
So I'm not seeing any other questions. I think you've marched through your slide deck for the day.
Have.
Okay, so let's talk about tomorrow. I see on our calendar that we have the Division of Public Health continued tomorrow. What does that mean?
That was in the calendar, but Janet sent around a revision. Public health is done today, and tomorrow you have behavioral health only, starting at 10 o'clock.
So we have a behavioral health and it's been properly noticed and it's at 10 o'clock tomorrow.
Yes.
Okay. So what? And then our location's not here tomorrow, is it? I think it's in room 104.
That sounds right. Let me just look that.
It's fun.
Okay. So,
Not sooner.
Ms. Tilley, once again, very impressive performance. You have a tremendous grasp of a tremendous amount of detail. I appreciate it. I always appreciate your responsiveness, if not your answers. But no, you're really very good, and we're lucky to have you there. And Mr. White, just you don't know, but we were chatting, the amount of detail that you've had to master in the last year to come up to speed and to be so good at providing sort of a top-down view after you've had to like rustle in the mud with the details is really excellent. It's very nice work.
I would give all credit to the team that's behind me. So
Well, they're all nodding. They took credit, so there's that. Did you have something, Representative Hull?
I concur with your comments. I wanted, when you're done, to talk about HB 49, not relative to the bill, but to something I'm handing out.
Oh, okay, I'm just trying to let these folks go. Is there any comment from the audience? Ms. Landry, you've sat here all morning. You got anything for us? Okay. Okay, well, with that, you all are dismissed and go enjoy a nice lunch. Thank you. As a comment, I think the division is doing a good job of, like, once you start asking questions, to just go ahead and continue to stay on the flow. And that is an unusual thing compared to the way some committees work. I think it's working for us. So I would like to continue doing that instead of coming back every time. I just think it interrupts the flow to do that. We have a request to talk about HB 49 for a moment. This is all very informal because that bill is now with the full finance committee.
I'm going to pass out a document that I found that talks about the.
So, before you do that, what's your advice? Should I close the hearing we just had? This is not a publicly noticed thing we're about to do.
I'm just handing out something.
Okay, so we're not going to discuss it, and okay. So, not HB 49 is not on the calendar for today. I don't know. Go ahead. Give me an interpretation.
It's been changed since then. It was no longer in the calendar today, but if you're only handing around a document, I think it's
All
fine.
right. So I'm going to close the work session of Division 3 relative to the public health. And we can, I don't think we need the cameras on anymore because you're just handing out
I'm
HB
just
49.
handing out a document that I found that deals with the relative costs for juveniles, and it